So I'm not going to read slide for slide. This is just going to be what was intended, which is wave tops, because the idea is that you guys go back and study this and quiz and quiz and quiz over and over and over again anyway. So, PrevMed, Chapter 9, PrevMed. Sanitation means promoting health through the prevention of human contact with hazardous waste, obviously. Medical does a lot of inspections. Vector. A vector is any animal capable of transmitting pathogens. I'll bring that one up. I have seen vector in different topics, different words that are PrevMed specific, like vector, and how does, you know, what transmits something to a host in this manner? Is it a vector? Is it something else? And you got to pick the right one. So just go through these and keep in mind. NAVMed Form 6240/1, Food Service Sanitation Inspection Sheet. Obviously that's a big deal, especially on ship. Prophylactic immunizations, IMS, susceptible hosts are us, we're always susceptible. Infectious agents are what cause bad stuff to happen to the hosts. Some that you might not know what they are right off the top. Aseptic technique's pretty obvious one. Bioburden. Bioburden refers to the number of microorganisms containing an object, contaminating an object, known as the bioload or microbial load. Dick-Bowie test is a diagnostic test of a pre-vacuum sterilizer's ability to remove air from the chamber and detect air leaks. It is not a sterility assurance test. Not what you use to test for sterility. I have seen a question that refers to something about testing for sterility. You know which test for sterility and equipment X, and that'll be one of the options. And obviously, that's not right. Contaminated stuff's on it. Contaminated laundry that pops up in a bunch of various places. It's referred to in whatever manual they get the mobile home stuff out of. Also brings up laundry facilities and stuff like that, and then breaks it down to this level again. So there's a difference between regular laundry and hospital laundry. That's why it gets brought up for us. No critical, semi-critical, and non-critical items. There's questions we asked about that. There's questions I've seen on past exams about that. Critical has to do with stuff that gets into the body. Instruments, materials that penetrate the skin, mucous membranes, or bone must be sterile before use. Examples: surgical instruments, periodontal knives, suture needles, stuff that penetrates the body. Right, semi-critical, next level down, instruments or materials that frequently contact the mucous membranes but cannot be sterilized because of their design or inability to withstand heat. Require high-level disinfection. Examples include radiographic positioning devices, plastic impression trays. Non-critical. Instruments or materials that do not normally penetrate or contact mucous membranes, which are exposed to splatters, sprays, splashing of blood, or touched by contaminated hands. Require intermediate level disinfection. Examples include the dental unit and medical exam table. This is why they wipe down all that stuff right before you get a dental exam and right after. Those would be considered non-critical items. Disinfectant's pretty obvious. The infectious agent is an organism that is capable of producing an infection. Infectious microorganisms or organisms capable of producing a disease in a host. An invasive procedure is a procedure that is invasive. Hope I don't have to break that one down. Nosocomial infection. I've seen this on at least 3 exams. It's an infection that occurs in a hospital setting within how many hours? I think that's really the key to that term. PPE is pretty obvious. If it's not, they may be harder. Occupational exposure, stuff you're exposed to because of your occupation during the performance of your duties. There's a lot of occupational risk forms. Hearing conservation data kind of falls under that because you're exposed to a lot of noise, especially on deployments and things like that. Saturated steam sterilization, sanitary sewer system, spray white spray is a technique used to sanitize. Everybody knows what sterile field is, I hope. Definition of sterile: sterility, sterilization, and sterilization area at the end. Sterilizer, gravity displacement type, and then there's a pre-vacuum type. Incoming steam displaces via gravity the residual air through a port or drain, usually near the bottom of the sterilizer chamber. The vacuum type is a sterilizer that relies on one or more pressure and vacuum evolutions at the beginning or end of the cycle. Unit dose. The quality of materials or supplies required to treat a single patient, referred to as a unit dose. We'll see that again in various places, like the quiz we made. So unit dose. Engineering controls. Know the difference between the different types of controls. I've also seen that referred to. So there's engineer work practice controls, are ways that they have you move around to make the environment more sterile, safer, etc. If you get into what's the name of that practice? Ergonomics. So there's a Navy guideline on ergonomics, and they break down the difference there too between work practice standards, engineering standards, or controls, sorry, not standards, and administrative controls. So it's kind of the same thing. Bacteria in a spore state remain alive but passive, resistance to the effects of heat, drying most bacterial cytochemicals. Viruses are microorganisms that are much smaller than bacteria. Viruses cannot live long or reproduce outside of the host. There's bacterial, animal, and plant viruses. Most viruses are susceptible to immersion in boiling water for 20 minutes. It'll be one of those dumb questions that falls in there. Protozoa, single-celled animals, fungi or plants that lack chlorophyll, like mold and yeast. Standard precautions are intended to reproduce the transmissions of microorganisms from recognized and unrecognized sources of infection. Universal precautions are a subset of standard precautions focusing on infection control methods to prevent the spread of disease from blood and bodily fluids and from direct contact. Hand washing is everywhere. 2 types of skin harbors: resistant and transient flora. 2 main hand washing agents: water-based and waterless. And that's pretty obvious too if you just stop and think about it, right? The washing increases the protective nature of gloves up to 60%. Don't reuse your gloves. It goes into the different types of gloves and what they're used for. More PPE stuff goes into the gowns, face masks, eyewear, headwear, transmission-based precautions, airborne precautions, obviously from your standard coughs and stuff like that. There's big hazards there. Also, droplet precautions from coughing, sneezing, or talking. Contact precautions. So obviously you should know the different types of transmission. HPV vaccine, that's a newer requirement. That's a question that's come up, how often do you HIV test? And tuberculosis, they've changed fairly recently, in the last like 5 to 7 years, I would say. You used to get that little under the skin test almost every year or every other year. And now you can go for like 3 years and just get the screening. And then I think it's every 3 years off the top of my head where you're supposed to get the actual skin test, unless you're a carrier. Medical asepsis, reservoir, port of exit, mode of transmission, portal of entry, host, concurrent disinfection, terminal disinfection. Infection control in the dental treatment room. So stuff like the water line should be flushed for at least 1 minute and then 30 seconds in between patients. I refer to them as dumb questions, because only through repetition are you going to remember that stuff, or through actually doing the job as a dental tech. If it's your job or a hygienist to go in and flush these things, yeah, you're going to remember that kind of stuff. If you're just Joe Corman and you've never worked in a dental treatment room, then it's going to be a little more difficult to remember this stuff, which is why I refer to it as dumb questions. But they can trip you up and cause you not to advance. Rinsing with mouthwash. HMs must never use their hands to dispense items from bulk storage containers. And obviously we talked about that. You got to wipe down all the equipment and stuff. That's that non-critical stuff we talked about. Using the spray wipe spray technique. More possible dumb questions. The dilution of bleach in mop buckets. Right? I've seen stuff like that pop up too, and it's really, really irritating on an exam. How often must mops be cleaned? I always pictured a bunch of guys who were extremely bitter about the exams they had to take, who were creating the exams and are taking it out on the other people. It's not true, mostly, but that's what I always pictured. So they come up with these questions. See if they get this one. Steps for what to do for an exposure incident. It can be super scary, like if you're pricked with a needle. Step away from the air contamination, squeeze the skin around the needle stick to expel blood and contaminants. I mean, that's kind of a, hope this works out. Cleanse the puncture site or flush the eye for 15 minutes. You should remember the 15 minutes. Follow facility protocol. And then with a needle stick, the blood samples are drawn over 12 months every so often to monitor for the disease no one wants. Management of infectious waste. There's also a singular instruction just on this. A liquid or solid, that you guys went over that already too. A liquid or solid waste containing pathogens in sufficient numbers and sufficient virulence to cause infectious disease. Pretty obvious, I think, what infectious waste is versus non-infectious or non-regulated waste. Infectious waste should be placed in containers and labeled with the universal biohazard symbol and the word biohazard. Bags must never be overloaded and should be double bagged and secured. Sharps should be in a rigid, puncture-resistant container. Liquid waste poured into a sanitary sewer system through clinical sinks unless prohibited by local or state authorities. Use the scoop method to recap. Definition of contaminated laundry, what to do with it. Don't store infectious waste without refrigeration for more than 7 days. So that goes back to that specific instruction. They'll go, you can have it here for 7 days, you can have it out for, I think, 10 days. In this instance, the 7 days would be the most important. I think you can keep it on site for up to 30 days as long as it's frozen, not just refrigerated. stored near the transfer site. Treatment and disposal methods for infectious waste. I know I personally, when I make some of these things, include these things for your reference later on. Tables that seem important, it's easier to pull them out and paste them into a PowerPoint, vice referencing them and then having you go back through the manual, which kind of negates the point of the PowerPoint to me a bit. So that's where that is for later. Specific solutions need to be used. I've seen a question on mops and using mops for the method used to clean operating rooms. So mops are the least desirable method. Surgical aseptic technique. More surgical considerations. Length of fingernails. How much antiseptic detergent to use when you're cleaning for surgery, how far up to clean, just above the elbow. Keep your hands above the level of the elbows. Just picture one of those medical shows all of you probably watched at some point. They're talking about their love interest and going into the surgery room and they always hold their hands up like this. It's actually accurate. How many strokes per surface area with the brush? And then sterile towel use, obviously. Gowning and gloving techniques. Again, reference for later. Questions? That was chapter 9. Give me 1 second. All right, disinfection and sterilization. Concerns about transmitting infectious agents such as hepatitis virus, HIV, have caused healthcare community to become more aware of the need to disinfect and sterilize instruments, materials, and other equipment to protect providers and patients. That follows chapter 9. Disinfection is a less lethal process than sterilization, which kills disease-causing microorganisms. Disinfection is achieved by chemical or heat means. The following are some of the criteria for chemical disinfection. I'll let you read through that later. The EPA classifies disinfectants as high, intermediate, or low level based on effectiveness and contact time. There it is. So you have your different types of microorganisms that they have to kill, and the level of disinfection needed. Factors influencing germicidal procedures. The bioburden, and that is again the higher the bioburden, the longer the exposure to the disinfectant is needed. General categories of liquid chemical agents. The four most commonly used: glutaraldehyde, chlorine dioxide, penicillin, phenolics, however you want to say that. Glutaraldehyde solutions classified as high level, and then 2 to 3.2% are FDA registered. So you do a lot of damage. In a good way, I guess. Chlorine dioxide, also used for high level disinfection of semi-critical items. Rapid action of 3 minutes for disinfection or 6 hours for sterilization. Iodophores are classified as intermediate level. Should not be used on white plastic or vinyls that are subject to staining. Obviously, because you're using iodine. At high temperatures, they can become unstable and may not be used as sterilants. Phenolics. They're classified as an intermediate level disinfectant. When diluted properly, they're used for surface disinfection, useful on metal, rubber, glass, and plastic. They're less toxic and corrosive than the glutaraldehyde, hence the need for their use. The semi-critical items requiring chemical disinfection. Three-way syringe tips, high volume evacuation, saliva evacuator tips, radiographic positioning devices, wipe it down with the EPA registered disinfectant. Breathing tubes are not autoclavable, requires high level disinfection. Non-critical items that require chemical disinfection, like the dental delivery system, which involves the chair, the unit, light, portable dental units, surgical table, chair, x-ray apparatus. Just gives you an idea of what they're talking about when they talk about these different levels of disinfection. The highest level of contamination control is the sterilization, because it destroys everything. Gotta have a central sterilization room. All sterilization takes place there. We usually even have one of those, at least on the ship I was on ship. And we got a nice little surge tech that takes care of all that stuff, checks it all the time. These are examples of sterilization equipment. Pre-sterilization stuff, you gotta worry about wrapping and packaging. to put it in the correct machine. Different types of packs, how long the shelf life is, so like 30 to 180 days, so 1 to 6 months for paper plastic peel packs. Different types of packs, the cloth ones, the seal packs. And here's the whole chart that lays that out as well. Okay, so the different methods, physical and chemical, know the differences and be able to identify which one is which. You know, so if they say pre-vacuum sterilizer is, you know, physical, chemical, or whatever, be able to identify which one it is, which category it falls under. Steam under pressure, the autoclave, is the most dependable and economical method of sterilization. Two most commonly used in the Navy. Has anybody ever seen the temperatures for steam sterilization reference? You have?
Dry heat one too.
I know I've seen dry heat. Is the Bowie-Dick test a sterilization test? Alright, so temperatures and times. That would be the two most important things I would take away as far as like memorization for a test on sterilization and disinfection. Especially when it comes to using this equipment. Other methods, chemical vapor. Process uses a mixture of chemicals including alcohol, formaldehyde, ketone, acetone, and water, heated under pressure to form a sterilizing gas. 20 to 40 minutes at 270 degrees Fahrenheit with 20 psi. No corrosion, rusting, and dulling since the water content is only 15%. The instruments are dry at the end. Disadvantages, adequate ventilation for the vapors. You may not be able to use that like on a ship. Steroid sterilization uses plasma state hydrogen peroxide. Good for the products that can't withstand the steam sterilization and are not absorbable. Different stages of steroid sterilization operating. Vacuum injection, diffusion, plasma vents. Okay, I got that off there. Different parts. Cassette. Cassette holds 10 cells. After 10 cycles, the message will print out, insert into cassette. Biological indicator test. Biological test best placed on top of an instrument. After the cycle completion, it will be removed and processed with the bacillus subtilis var 92. Biological control. After 24 hours, test results will be documented in a monthly report given to the ICO. Ethanol oxide. Ethanol oxide gas uses relatively low temperatures for sterilization. Sterilization can be achieved in 3 to 12 hours at 120 degrees Fahrenheit. Lengthy aeration time of at least 16 hours must follow each cycle. That's a big disadvantage. Glutaraldehyde is the only liquid chemical capable of rendering an item sterile. I would probably remember that. So long as it's submerged in the solution for 10 hours, anything less than 10 hours is considered disinfection. Critical items that require sterilization: handpieces, burrs of diamonds, endodontic files, gates, lid, and burrs. UMed 6600.10. Another reference for you to look over. Sterilization monitors, there's 3 used today. That really does screw it up. Physical, you look at the gauges, reading and recording. Chemical, internal and external, involves heat-sensitive chemicals that change colors. To show you what's going on. Internal indicators, chemical dyes that change color when exposed. External, chemical dyes that change color upon short exposure. If the indicator fails, notify the ICO and the biomed repair and secure for use. Biological monitors are designed to assess whether sterilization actually occurred and to confirm that all bacteria and endospores are controlled. It's recommended that at least weekly, but preferably daily, monitoring is done. When positive biological monitoring occurs, notify, record. On a second failure, notify biomed. Again, record and then retest. Everybody good on that? Sweet deal. Anybody need a break? Or we can do that right after this one. So we stay on topic. Technically, I'm supposed to be done. This one's the first half hour, the second half hour. Alright. So on to some stuff that isn't sterilization, disinfecting, or PPE. Okay. Health refers to the mental, physical, and emotional state of being, which enables proper performance of one's vital functions. Patient rights and responsibilities. Again, UMed Instruction 6300.10, Chapter 3. You should know that. HM Occupational Standards, NAVFIRS 18068 Series, Chapter 40 and 41 define minimal technical skills required of a hospital corpsman. And SMDR is usually chief or senior chief in the hospital corps. Malpractice occurs when an individual delivers improper care because of negligence or practicing outside standards of practice. Legal limits of practice are defined in each state by certifications or qualifications. HMs are legally governed by Navy regulations and UMed policies and can only perform those assignments and duties while under the authority and direction of the U.S. government. Stand your swim lane. Ethics, everybody kind of know what ethics is? Have a general idea of what ethics is? It plays into almost everything these days. Integrity, personal appearance, don't look like a dirtbag. Interpersonal relations, also super touchy subject, especially when you get on the outside. We get into what you can and can't talk about in the workplace and all that, what might be offensive, what might not. Obviously, as HMs, we deal with a whole bunch of different people. So you have to be open-minded with who you both work with and interact with as patients. You can be prepared to accept people from different religious beliefs, genders, different races, different cultures, different ages. Don't be prejudiced or simple-minded. Communication. Communication is also important everywhere. Communication process consists of 4 basic parts. Has anybody done classes specific to communication? That they do? I know our chief set this up a couple years ago in the battalion, which is kind of weird, but it has its values. Sender of the message starts the process. The message is the body of the information. Sender wishes to transmit to the receiver. The receiver is an individual intended to receive the message. Feedback is the response given by the receiver to the message. So the 4 parts are the sender, the message, the receiver, and the feedback. You have verbal and non-verbal communication. An example of nonverbal would be, anybody? Body language, that's like the biggest one. You can also be transferred in like how you dress, your personal appearance could be nonverbal communication. Pretty much everything you do is a form of nonverbal communication to somebody. Barriers, physiological barriers. Speech defects, vision problems. Physical barriers, noisy environment is going to affect your communication. Psychosocial, that's where your own perception comes in, or even their perception of you plays in, that can create a barrier. And psychological, which says is the most common cause of communication failure or breakdown. Have good listening skills also. Patient contact point program. Initial contact point is the physical location where patients experience their first communication encounter within the healthcare facility. Contact point is a place or event where a contact point person and the patient meet. Contact point person is the healthcare provider in any healthcare experience who is tasked by role and responsibility to provide service to the patient. Patient contact program is the overreaching program facilitating two-way communication with patients. So both complaints and compliments are documented, tracked, and corrections made to improve the NCIDC experience. We do this everywhere, like ICE. Right? You can call ICE and report just about anything. It's MTF, DTF, or a gym on base. Therapeutic communication is defined as a face-to-face process of interacting that focuses on advancing the physical and emotional well-being of the patient. There's three purposes: collecting information to determine the illness, assessing and modifying behavior, and providing health education. The patient must have a therapeutic reason for invading the patient's privacy. Patient education, essential part of healthcare delivery system. You can give them medicine all day, but if you don't tell them, like rice. If you don't use patient education, you're just handing them Motrin and a bandage and hoping for the best. Goals include assist individuals so they may acquire knowledge and skills that will promote the ability to care for themselves more adequately. I'd say that's the main one. Influence individual changes and support behavioral changes. Reporting and assessing using the SOAP method. Naval Medical Department uses a SOAP note. Refer to Chapter 16 of MANMED. Subjective, objective assessment and plan. Anybody need me to go into depth on that? Good. Different assessment criteria. General appearance, behavior, your position, skill level, eyes. You can tell by the look somebody's giving you what they're thinking a bit. Ears, are they having trouble hearing? Is he holding pull on his ears? This all goes into stuff to look for in the different areas as you're doing yourself now. Everybody good? Solid. Anybody need a break? Moving on. Alright, inpatient care. Medical patient applies to any person who is receiving diagnostic, therapeutic, and/or supportive care for a condition that is not managed by surgical, orthopedic, psychiatric, and maternity-related therapy. Has to do with lab tests. What you must do for a lab test. Responsibility for preparing and administering medications often falls to the HM. Different references you can use when dispensing medications if you don't know what you're doing. General areas of patient teaching needs as the patient approaches discharge. Follow-up appointments, modification activities, modification in diet, medications that they're going to keep taking, and measures to promote health. What can you do to make yourself better for the future? Primary reason for prescribing rest is to prevent further damage to the body or body part when normal demand of use exceeds the ability to respond. Key elements of prevention include turning the patient frequently, providing skin care daily or twice a day to stimulate circulations. Surgery, emergency surgery occurs when surgery is required immediately. Elective surgery is stuff that needs to be done but can be scheduled later on. It's not life-threatening. Every surgical patient requires at least specialized care at 4 phases, which consist of pre-op, op, recovery, and post-op. Everybody should be fairly familiar with those. Those are pretty common terms. Pre-op, physician is responsible for explaining surgical procedures. Staff should assist in reducing fear and anxiety. If they want a priest, get them a visit. Proper paperwork, SF-22, the anesthesia. Can't do anything without that form. Need a parent or guardian if they're under 18. 2 major factors during the operative phase are positioning and anesthesia. Specific surgical procedure will dictate the general position for the surgeon. Anesthesia is defined as the loss of sensation that make a person insensible to pain without loss of consciousness. 2 major classifications of anesthesia are regional and general. Most common type of anesthesia is the most common type of anesthesia the HM will administer is the nerve, I believe. Regional. Spinal anesthesia inserted into the subarachnoid space of the spinal canal between the 3rd and 4th lumbar space, or between the 5th lumbar and 1st sacral space of the spinal column. So that being another one of the super awesome questions. Different styles of anesthesia: epidural blocks, saddle blocks, caudal blocks. Stages of anesthesia: induction, excitement, surgical, and toxic. There it is again, 1, 2, 3, and 4. Toxic you don't want to get to. That'd be bad. Recovery stage consists of a period that begins at completion of operation and extends until the patient has recovered from anesthesia. Recovery takes place in the post-anesthesia care unit. Routine care, vital signs, airway, IV monitoring, watching the dressings, watching circulation, watching level of responsiveness, watching for side effects, heavy monitoring of the patient. Post-op phase: after the condition has been stabilized, will be transferred to another area. Goals are to promote respiratory function, cardiovascular function, renal function, nutrition and elimination, fluid and electrolyte balance, wound healing, encourage rest, encourage movement, and preventing post-op complications, which can be many. Orthopedic patient. Rehabilitation is the ultimate goal when forming orthopedic patient care plan. So you're dealing with casts and things like that. Immobilization consists of applying casts or splints, the use of traction, Orthopedic pain is commonly described as sore and aching. Cast can be applied or short, and long arm cast and short leg cast. And that goes into details on all those. Cast or applied patient must be given written and verbal instruction. For leg cast, it will take 24 to 48 hours to completely dry. There's another one you might need to know, you might ask.
Warm water and vinegar was on the last test.
There you go. Use of assistive devices to help with getting around. Canes. There's any different types of canes. I've seen a question on canes before personally. How much weight it can support, or there was another one on what type of cane, and kind of described when you had to pick. Crutches provide better stability than canes because they have 2 points of contact with the body. 2 types of crutches are axillary, which is the most common, wood or aluminum. Forearm crutches, crutch leg should be 6 inches in front of the foot. Walking techniques or gait techniques for crutches: 2-point, 3-point, 4-point, swing through, swing gait, tripod crutch gait. Walkers are used when patients require maximum stability and support from an ambulation device. Indicated for general weakness, limited ability to bear weight on lower extremity, poor balance, confused, early gait training. 5 types of walkers: standard, wheeled or rolling, reciprocal, one-handed, also called the Hemi walker, stair climbing walker. 12 inches in front of the patient, 20 degrees. 12 inches in front of the patient. Hand grip should sit at wrist crease. Hand grip. Measure proper height of the walker. Have the patient stand upright with the elbows flexed at 20 degrees. Terminally ill patients have an urgency to fulfill spiritual, psychological, cultural, economic, and physical needs. Healthcare providers' responsibility to be attentive and perceptive to patients' needs and provide whatever support they may require. Dying is an aspect of life and is often referred to as the final crisis of living. 5 stages of death: denial, anger, bargaining, depression, acceptance. Anybody seen a question on this? No? See a lot of nods. I think I have too. It's been 2 years. Okay, patient safety. The environment is defined as the physical surroundings of the patient and includes such things as lighting, equipment, supplies, chemicals, and activities of the patient staff personnel. TJC and AHA have identified 4 major types of accidents that continually occur to patients: falls, electrical shocks, physical and chemical burns, fire, and explosions. Patient's bed is the most basic item that is the common cause of falls. There's preventative measures you can take. Electrical safety considerations: don't use electrical equipment with damaged cords. Do not attempt to repair defective equipment. Can only be used when grounded with a 3-wire cord and a 3-prong plug. Do not use extension cords unless approved. Never put water on it. It's pretty common stuff. Common cause of burns, particularly in the elderly patients and diabetics, is the hot water bottle. Should never go above 125 degrees Fahrenheit. For heating pads, make sure pre-use inspections and periodic safety inspections are conducted by Biomed. Ice bags or cold packs can cause local frostbite. Gotta watch that. Fire and explosion precautions: keep passageways clear. You don't want something blocking the hallway. Ship bursts into flames. That can be bad. UN Instruction 6200.12, tobacco use in Navy medical department activities. Smoking is no longer permitted in Navy treatment facilities. Environmental hygiene. Hygiene is described as practices that provide a healthy environment. Environmental hygiene practices focus on 3 areas: safety, environmental control, and infection control. Goes back into concurrent and terminal cleaning. Research has shown the use of color is calming and restful to the patient. Noise control is necessary. Air control, humidity control, good ventilation, all help people heal. Isolation rooms should have proper negative pressure. Operating rooms required to have positive pressure. Any questions? Everybody good? What did you do last year? What did you do last year? Get my phone going up there. 13 and 14.
Let's motor through this. Nutrition and diet therapy, chapter 13. Alright, eating healthy is key to maintaining health. Eating properly after being diagnosed with nutrition-related disease is critical in long-term disease management. Of course, I didn't have time to review these, so bear with me. Of course, energy in equals energy out. A person can maintain a weight level by expending as many calories as are consumed. This kind of goes with this stuff that H1 Brookie taught the other day. BMI, we all know what BMI is. We have to deal with this for PHA, so I'm not going to go into it. Food pyramid, 5 food groups are right here. Grains, vegetables, fruits, fats, oils, discretionary calories, milk, meat, and beans. Pretty sure this changed from my food pyramid to my plate. Anybody got any info on that? Or anything against that? No? Pretty sure this changed though within the last 2 years. Not that it matters for this. Nutrients. Nutrients is a substance that contributes to growth or maintenance of the body. That's good to know. I've seen that in previous tests where it says, what is a substance that contributes to growth or maintenance of the body? You got your 6 essential nutrients right there. Only 3 of the 6 contain calories. Water, medium for chemical reactions in the body. Know that the human body is made up of 60% water. Alright? Loss of 5 to 7% can result in a heat injury, which we've covered 3 to 4 times in different instructions throughout this class. Carbohydrates consist of between 40 and 60% of a healthy person's diet. Alright? They provide 4 calories per gram. They also provide energy to the cells. Fiber is non-digestible, non-essential, plant-based polysaccharide. Alright? You need to know these differences between carbohydrates, proteins, etc. Alright? Proteins, building blocks of the body. The recommended amount of protein for all adults is 0.8 grams per kilogram per day. For a person who weighs 176 pounds or 80 kilograms, the person requires 64 grams of protein per day. Any questions on that? Fats. Fat is calorically dense and at 9 calories per gram. General recommendation is 20 to 35%. All right. There are 4 key types: A, D, E, and K. All right. And then there's two types of fat: monosaturated and polysaturated. It's good to know which of those vitamins right there, A, D, E, and K, also treat what specific chronic diseases. Alright, so look that up on your own time. I think we cover it later on, or if not, I would know that. Alright, trans fat is bad. Omega-3 fatty acids lessen the risk for heart disease. I can't read what's in the yellow. Cholesterol. Alright, too much is bad and cause heart. And then phospholipids created in the body. And then I can't really see the graph too well, so just take a look at that. Alright, so your fat-soluble vitamins include vitamins A, D, E, and K. Alright, that's good to know. Water-soluble vitamins include vitamin C, thiamine, riboflavin, niacin, B6, B12, folic acid, pantothenic acid, and biotin. alright? Both the major and trace minerals serve critical functions in the body, okay? It's good to know all these. Make sure you look over them and understand them. That Master Chief Breaker's guide that Chief talked about, there's a good supplement and ditties in there to remember this stuff. Alright, so look over that if you haven't already. Diet therapy. Special diets are used in the treatment of disease are often referred to by specific names that show a special composition, low sodium, low cholesterol. Alright, so different diets for different diseases, okay? You got the clear liquid diet, the full liquid diet, dental liquid, blenderized liquid diet. Of course, that's for somebody whose jaw's probably wired shut. Soft or bland diet, somebody suffering from GERD, or somebody's having, a gastrointestinal issue, we often tell them to do a bland diet. Pureed diet, never really seen that used, but there's the breakdown of that. Looks like it talks about people recovering from stroke have failed a modified barium swallow, or have complications with chewing. High calorie, high protein diet. Calorie restricted diets promote weight loss, of course. Protein restricted diet helps treat patients with renal disease or hepatic disease. Why wouldn't you want a lot of protein if you have somebody with a renal disease?
Kidneys.
Yep, exactly. Puts more stress on the kidneys. Residue fiber restricted diet, high fiber diet, diverticulitis. I'm pretty sure I've seen that before. Alright? So it was something along the lines of, what diet would you use for diverticulitis? High fiber. Alright, so understand what correlates with what. Low sodium, low cholesterol, low fat cardiac diet. Gluten-free for celiac disease, which is huge right now anyways for a lot of people. Nutritional support, you have oral supplements, parenteral nutrition, refers to feeding a patient via vein, no functioning GI tract, and then enteral nutrition. And then nutrition plays a critical role in preventing and managing disease and conditions. The base of a good diet always starts with the food guide pyramid, focusing on the 5 main food groups, and then there's always good info on NKO. There's a class you can take that talks about nutrition. Any questions? We'll take a break after this one, alright? Alright, chapter 14 is physical exams. Okay. The purpose of an examination is to identify physical defects and psychological problems that would compromise a member's ability to perform their duties. Alright? So it's important that we get our physical exams on point. Correct? So the people that are authorized to do physical exams, I don't need to beat that in your head, you already know. Your IDCs, your medical officers, physician's assistants, etc. Of course, IDCs have to be practicing under a medical officer's license. Alright, requirements. Again, I'm not going to beat this in your head. This is all stuff we deal with on a daily basis. If you don't understand this, I recommend reviewing this portion. Alright, these are the key things that are required in special duty screenings or regular physical exams. Okay, so entrance physical exams are normally performed by METs. They require a 2808 and 2807. and then both of which are filed in section 3 of your medical record. PHA, of course, is conducted annually in accordance with SECNAV instruction 6120.3, all right, which we've talked about already, I believe, in this class. And then it's not considered complete until the member has met all the IMR requirements, all right? And it's conducted when? Annually. Yep. Separation exams are required for personnel separating from the Navy, the Marine Corps, and active reservists serving 31 consecutive days or greater on active duty, okay? For members not qualified due to service incurred or service aggravated injury or illness, a notice of eligibility may be appropriate. See that instruction right there. Special duty physical exams are all based on what exam you're talking about. We've already covered that in depth in a previous instruction. You got your overseas operational suitability screening exam. For members that are going overseas or to remote assignment, this is to make sure they're eligible. And then families may also need to do it to see if they need medical, dental, or educational requirements to determine if they need to be enrolled in an exceptional family member program. Suitability screening prevent the arrival of service members and families at duty stations with special requirements, or a duty station that may not have the capabilities to take care of that family. This is where we catch that. Has anyone encountered somebody showing up to your command that didn't complete this properly and then their family member wasn't able to be taken care of? Yeah, happens all the time. Overseas screening facility often lets these fall through the cracks, and then as you're the LPO or whatever, you might have to be scrambling around trying to get the care for this person, okay? Where was that at? Overseas? Happened to you?
Yeah. I don't Singapore, and I did the Navy after that.
Yep. And it wasn't your fault. Medical surveillance exams, of course, we talked about those in terms of, the food handling and whatnot, as well as barbershop exams and stuff like that. Hearing, asbestos. Through these exams, not physical nature, they are used to produce specific information with regard to individuals' health during actual or potential exposure to hazardous materials. Of course, here we're talking about the hearing conservation program. You got your flight deck exams, aviation ordnance, ammo handler, etc. Medical eval boards, I'm not going to go into this. Lynn, you guys know all that. If you don't, refer to this. We've already talked about this and feed it into your heads. An abbreviated board report is used when a member is expected to return to full duty and after an adequate period of treatment, okay? And that's in regards to temporary limited duty medical board. Any questions? All right, take a 5-minute break. Desmond, what do you got?
15 through 17?
Okay.
I usually 15 through 25.
Okay.
In succession with no break.
Check.
In detail.
Aye.
Reading straight from the manual.
That's the hardest part. Just trying to church that shit up.
And then you want some dumb. You said 15 through 17?
Yeah.
15, 16, 17. Yeah. Didn't have a limit.
Mr. Horner. I swear to God, I flew back there last. No, I text her. His 9 January 15. A screenshot of something. You think I should send her that? That was your recommendation.
it's seven, because two is up here. So the first one comes with two.
Yeah.
Three.
They won't do it.
They won't.
So
Is
five.
that, 6 is definitely right up all of them.
No, it's in the hospital.
Five is above.
Take this one off.
Five is just in that down. And they go up, and this one is the second.
I'm also, yeah, I don't know if we'll see them much.
They might, right?
So yesterday I went over biological warfare and nuclear, right? Speaking about biological warfare, what are some toxins or some agents that can be used? Remember? Ricin, right? Plague, anthrax. Okay. How do we mitigate those factors before we go out to no CONUS or austere environment? Chemoprophylaxis, right? So a lot of this stuff, when you're going to take these tests, look at these instructions that overlap, right? So when we're talking about biological warfare and we talk about chemoprophylaxis, okay, what hits? Anthrax, JEV, those are the type of things that you're going to want to know, because that's 2 instructions for 1 question, right? So I've seen that a lot. What is like the biggest? When we're talking about biological, we talked about like there's 4 different ways that they can introduce those agents into the environment. What is the one that's going to cause the greatest amount of casualties? Aerosol, right? Because it gets fucking everywhere, right? Released in the air, you breathe in, gets into the soil, right? How many people are from the freaking country around here? Like, who's a fucking hick? Raise your hand. Huh?
Like from here?
Like from fucking Podunk, Ohio, or fucking Texas, or freaking Oklahoma. Fucking grew up fucking picking corn and shit like that. Anybody? Alright, well, I did. Okay? So, when you go to talk about corn and stuff like that, anthrax is naturally in those type of crops. Okay? And believe it or not, there is parts per million of acceptable allowances of anthrax. So, what about quick review about nuclear stuff? Which deliverance of that nuclear capability causes the most casualties? Yeah, right? So you have that high air burst that's at how many kilometers? 50. Alright, 50 kilometers in the air, right? And it goes for a long distance because that fallout just freaking rains down, right? And then you have that ground burst that's right above the ground. But what makes it the ground is that the fireball actually makes contact with the ground. Alright? That's where you're going to get the biggest explosion on the ground. Right? Okay, those are the 2 differences. So we're ready to do this friggin' dental bullshit?
Real quick, when it comes to these topics, like you were saying, a lot of them overlap, right? And so like chapter 9, and then I brought up the instruction you guys just had the other day, that kind of went over some of the same stuff. Would you rather have it broken out like it is now? Because if you just do this section is just for the corpsman, it's so damn big. But you think it would be better to tie these things together in like a morning?
You mean like all the...
So yeah, you have the instruction on disinfection and stuff like that, and then you do chapter 9, and then you know
I
what I
think
mean?
it's better to bring it up after a while than reinforcing it.
Yeah. Okay. Just a side question for future.
rock granite.
Like I said, yeah. Something wrong with you.
Oh, no, I was just fixing the screen.
Alright. Y'all ready to rock? Alright. So, when we're prepping for dental readiness, right? Corman is gonna always pre-screen what we're gonna do. So, know that NAVMed 66/3. Alright, and we wanna look for the answers always yes. Okay, those are our big hitters. Alright, so this is our big deal, our headache that we always deal with. The four classes, right? Everybody knows that, so we'll push through. Alright, so type 1, alright, the most extensive dental examination. Okay, it goes through all these things. Cancer, use the mouth mirror, explore, alright, yada yada yada. Alright, type 2. Okay, know this form, Easy 603. Alright, that is that. Alright, and then type 3. Okay, this is, we're doing diagnostic procedures. And then type 4, right? We're hitting. We need to get our freaking little examination, and then we're ready to go. Okay. All right. You have your suitability screening before you're going to go anywhere. The Navy wants, or the military wants you to know that you're not going to incur any dental emergencies that's going to take you away from those situations, right? So you're going to go through and do your dental screening, as well as you have to do the exact same thing whenever you're going to go somewhere. So separations, retirement, same, all right? Know if there's a missing tooth, we're going to mark it out with an X. Also know how to number and identify the teeth. If there's any restorations, you're going to draw that restoration in, okay, along with non-metallic permanent restorations. Gold restorations, you're going to color them in. Removal of partial dentures and complete dentures. All right, we're going to mark the missing teeth as previously described, right? We're going to do the large X. We're going to place a horizontal line between the outline of the teeth and the numerals designated the teeth replaced by said denture, right? On the forensics examination form, in the remarks section, we're going to describe the type of denture. Yes? When we're talking about fixed partial dentures, we're going to outline each aspect, including the abundance and the pedontics. All right, show parission and junction of the materials and indicate which type of material is used. Okay. And that's by coloring in outlines set 4. When we're talking about a root canal filling, we're going to draw lines in the area of the roots, okay, that have been affected. All right, deciduous teeth. How are we going to do that? Somebody read for me.
Circle the appropriate alphabetical designation on the Brunswick and current status forms if deciduous teeth are present.
Okay? And then when we talk about supernumerary teeth, we're going to mark them with S. Drifted teeth, we're going to chart the drifted tooth and draw an arrow from the number of the drifted tooth. Okay? We see certain sections marked with S, and we also have the arrows from the number to where the teeth is drifted. All right, now we're talking about that dental exam, right? Easy 603. We're doing it for T1, T2, okay, separations, and then our 2808. 2808, we're looking to go overseas, right? Or PCS, or get out. That's what it looks like. Questions? All right. And just think of the 603 as your dental soap note. How do you get to the next one?
Hit escape on the keyboard, dude. And then look over here and have them all over.
The next one's going to be chapter 60. Bye. Okay, when we're talking about operative dentistry, it's the area of dental concern with the prevention and treatment of defects in the tooth enamel and dentin. Okay? There's always questions on the test revolving around enamel and dentin. I know the difference. Operative dentistry includes the treatment and restoration of caries teeth with metallic and non-metallic dental materials. These materials are usually amalgam or composite resins, and glass ionometer restorations. Since many patients need treatment that is provided in operative dentistry, this is where most dental assistants are assigned. Okay, so we have specialties, right? All right, one of them is preventative dentistry. It's to assist the patient in either establishing control of dental disease or continuing to maintain good oral health. That's the most basic. You know, where you're getting in and scraping you with the hooks and whatnot. Okay? Endodontics, okay, is the specialty of dentistry that manages and prevents diagnosis and treatment of the dental pulp. Okay? That's what we want to preserve. Dental pulp goes bad, you have total tooth decay, right? All Alright, prosthodontics. This is a specialized area of dentistry involved in replacing missing teeth. And oral maxillofacial surgery. That's exactly what it says. Periodontics is the dental specialty involved in the diagnosis and treatment of diseases and supporting tissues. Okay, and orthodontics is a specialty of dentistry that is concerned with the correction and growing, straightening of the teeth. The hand cutting tools, you have excavators, chisels, hatchets, hoes, and gingival margin trimmers. Okay, those are all hand tools, little hooks and stuff like that they're going to use for those specialties. Right. The spoon excavator is double-ended, has a little hook on it. It also has a spoon. Okay, it's used to remove debris from tooth cavities. You got to clean all that out before you cap it off, or you're just going to cap that bacteria in and rot the tooth. You have your chisels. Okay, when you're going to get in there for tooth extraction or whatnot, you're going to have to get it and split the tooth, right? Make sure that you know, when you're going to cap it, everything's smooth and fits nicely. Same with the hatchet. Alright, hoes are used with pulling motion. They're smooth in shape to the floor and all sides for cavity preparation. Gingival margin trimmers, GMTs, are modified hatchets that have working ends with opposite curvatures and bevels. Right? They're used to trim, smooth, and shape the gingival margin for cavity preparation. Alright, this amalgam carrier. This is what they're going to use to dip and then put it on your tooth. Condensers are used to condense and pack the amalgam. Alright, make sure that it's hardened and will last. You have carvers. These have sharp cutting edges and do exactly like that. They carve out that amalgam to make sure that it looks like a natural tooth. Burnishers, they smooth, okay, kind of like a little finisher. Composite resin instruments, they're just used for the resin, okay? It's kind of like the amalgam transfer, same with these resin instruments. An aspirating syringe is used to inject local anesthetic. Alright, rubber dam. Simply that. It's going to isolate where that dentist is going to work on a specific tooth. They want to keep it dry. Which is kind of hard to do, right? Because you're always secreting oral secretions. But it needs to be dry so that amalgam or resin can set. There are different types. Now you have your forceps. That's how you're going to introduce that rubber dam, and then you have a rubber dam frame. Right, you have a matrix container. It's used to hold the matrices firmly in place around the tooth. matrix retainer and metal bands are used in combination to temporary mold, alright, that resin or amalgam, okay? We have a Toffelmauer retainer. This is available in 3 different designs. You have a universal, contra angle, and contra angle junior. Alright, these matrices are used to approximate the original surface and hold the restorative material in proper form and position until it sets. Alright, once it sets, then they're going to use a carver and everything like that to trim it down. Right, and then they're going to ask you to bite down, make sure it's not too, you have a natural bite. Okay, I've seen this on a test multiple times of where you know, your hands are supposed to be placed in while assisting the dentist. Okay, it's based on a clock concept. So, and it's divided into 4 zones. Know the zones: the static zone, the assistant zone, the transfer zone, and the operator zone.
There's something in the last test with left-handed dentist or some shit. Similar to that, the clock zone.
Mm-hmm. Yeah.
I have no idea what to do on that one.
Yeah. So, hopefully it's going to come up here pretty quick, but that's, I would definitely know these zones. I know that the sag zone is from 4 to 8. Okay, pretty much that's where nobody's at. Alright, the assistant zone is from 2 to 4.
I think it was the assistant zone is the one I saw on a previous test.
Mm-hmm.
Specifically, where does the assistant sit in reference to blah, 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 or what zone?
Alright, and then your instrument transfer is in 4 stages, right? When you're actually working, the signal, pre-transfer, and mid-transfer in the working stage. Alright, in the working stage, you're going to pick up the next instrument, okay? And insert tray with the left hand, ready to transfer it over to the dentist to work. You want to grasp between the thumb and the first 2 fingers, okay, to make sure that you don't touch the ends and keep them sterile. The signal stage takes place when the dentist signals for the next instrument. During the stage, the dentist maintains the fulcrum, the finger rest, and the pivotal action is you don't want to touch the ends. The pre-transfer, you're going to grasp the used instrument firmly using the little finger. Alright, the corpsman may prefer to use the last 2, even the last 3 fingers to receive the instruments. You don't want to drop them. Alright, it would suck to get a tool in the face. And immediately following this action, you want to carry out the mid-transfer stage. The mid-transfer stage is where you're going to place the instrument into the dentist's hand with the working end positioned towards the treatment site. And the treatment site is located on the maxillary arch, point the working end of the instrument up. When the treatment site is on the mandibular arch, position the working end down. Super cool diagram. Alright, aspiration. We use this to remove anything that we don't want in there, right? Whether blood, mucus, saliva, or other debris. This is done by using a high volume evacuator, right? HVE. Okay? I would know this, right? So this is gonna, one of those things that overlaps. Okay, your VMET instruction 6260.30. Alright, we're talking about mercury control. hazard potential. All right. Any questions? All right. Let's push to this last one. We're almost caught up on time. All right, let's see. 17 is the last one. Oh, God.
Go, girl.
Radiology technicians are hospital foremen who perform diagnostic imaging. Okay, you have general diagnostic radiographers, computed tomography technologists, a rotating X-ray machine. You have magnetic resonance technologists. Okay, uses strong magnetic fields. You have cardiovascular interventional technologists, CTs. All right, they work with this. Nuclear medicine technologists, sonographers, mammographers, and oral radiology. These rays were discovered in 1895 by Wilhelm Conrad Roentgen, and he experimented this first with a device called the Crookes tube. First dental radiograph was taken in 1895 by Otto Walkhoff. These electromagnetic waves, they're long waves, okay, and the wavelengths are extremely short. They travel in straight lines at the speed of light, and they produce hidden images that are made by processing, all right? And they irritate living cells and can cause necrosis if administered in large amounts. The X-rays are produced when in the tube head when the tungsten target is bombarded by a stream of electrons. In dentistry, the X-ray image is controlled by 4 factors. You have kilovoltage, exposure time, millimperage, and film target distance. Do we have any like rad techs in here? No? One of my buddies that's been doing it for a long time, he always says like the exposure time and the target film distance is always like a huge deal regarding the quality of that image. Alright, we always want to go with the alarm, right? As low as reasonably achievable. You don't want to expose your patients to a bunch of x-rays. Alright, the coroner should always drape the patient in a lead apron and thyroid collars because you want to shield the reproductive organs and thyroid glands. The only difference is when you're taking a panoramic view, because it doesn't make a lot of sense to shield those things when you're trying to go all the way around, right? X-ray technicians use dosimeters, all right? Those are those little tag deals that they carry around and measures how much x-rays that they've had. Every 6 to 7 weeks, they collect it and measure, okay? 0 REM is radiological equivalent or mammal. Exposure is expected, and that's what they're going to measure, okay? If it's over that amount, okay, of 0.010, then they cannot take any x-rays for a while. Non-radiation workers should never be exposed to doses equivalent to 500 microRNs, all right, per year. It's pretty basic, but never stand in the path of a central X-ray beam, never hold an X-ray film packet in the patient's mouth, and never hold the tube head or cylinder during exposure. Always stand behind said exposure. Title 10, Part 20 of the Code of Federal Regulations. All right, that sets the standards of protection against radiation. Additionally, it sets the annual total effective dose. And then the P5055, all right, look, that's a reference that's going to cross, that overlaps. That is the Navy's Radiation Health Protection Program. Some signs and symptoms of excessive radiation exposure. Loss of hair, redness or inflammation of the skin, and that's caused from that tissue damage that you're exposed to. Blood count changes, okay, it'll kill those cells. Ulcerations, sterility, genetic damage, cancer, leukemia, and death. I heard the last one really bad. All right, the Precious Metal Recovery Program. At the MUBET instruction 4010.3. Again, that's another one. It's always on the test. Always on the test is your Precious Metals Recovery Program. Nosocomial Infection Control Program. What is that?
Infection from the hospital.
Infection from the hospital, okay? All right. And Dental Infection Control Program. A couple of times on that last one, I saw at the very end that was in parentheses, check and look at the patient's positioning, because that's another easy question that you can get. Kind of like how in the dental program we're talking about where your hands are supposed to be. I've seen several times that question as well, is where you should put, the hand or forearm or ankle to have this X-ray. All right. We always want to ask the female if they're pregnant, okay, because it can cause birth defects. We want to remove items such as eyeglasses, dentures, earrings, any other objects around the head or neck. But again, we're looking at those type of things that are metal, right, that would block a clear and prevent a clear image. Paralleling is the preferred method. Use a paralleling device along the axis of the tooth using a locator ring, indicator rod, and a bite block. And bisecting angle, when the paralleling device is not available, all right, we go 8 inches. Okay, when we're using that bite block, they're going to position that camera 16 inches. We're not, they're going to do 8 inches. All right, you have vertical angulation. We're going to place the camera up and shoot down. And you have horizontal angulation, that's side-to-side position. Maxillary landmarks, okay? Your incisors, your cuspid, and your bicuspids. Your mandibular landmarks, your incisors, cuspid, bicuspid, and molars. All right, there's 5 steps. Okay, you have the developing, then rinsing, fixing, washing, and drying. Any questions? Who's up next?
Alright, take a quick 5-minute break.
One.
5-minute break.
Right, go.
Chuck that. Master Chief, how you doing? Good? Yeah, I think we all are. Okay, I'll upload it after, the day ends if it's not already in there.
Just let Alan go
So it'll
before
send me
me.
an email.
I mean, she's only teaching 2 classes, I'm teaching 4, so.
Yeah, definitely. I didn't ask for that, honestly.
I feel like it's a smaller group than last time. I feel like last year was bigger. Class-wise.
Yes, it was very.
They had class.
I did last week, isn't it?
But I'm not.
Did you do last week? We did it.
We gotta keep around.
division. So we got one hospital. How many? Who's from the hospital? Obviously the guy in blue. Well, dental. Okay, great. So you're from the hospital. Everybody else is MEF. How many from division? Few. Okay. Wing. Couple. You guys actually down from Cherry Point, or you over at New River? Nice. Good. Okay. And MLG. Bunch of the others. Okay. All right. So hey, how many people have been in this before? Went last cycle. Raise your hand high so I can see. So just 3 or 4. So everybody else is first time. Okay. Good. What do you guys? 3 days? What is today? Wednesday? Getting old sucks, man. What's okay? So you guys are a few days into it. Hopefully you're getting something out of it, and hopefully you understand the amount of work that's gone into this, both to build it and then to keep it up. This is the second run. It's getting better. You know, they're live streaming. Hopefully I'm not on right now. But
I think you are.
okay. Well, hello, internet. So I just ask one thing of you guys. You know, it's great that you're here. You're paying attention. That's fantastic. This is obviously for you, built by sailors for sailors, right? Please perpetuate this. Make sure that you're getting this out there to your peers and let them know about it. Also, I would ask, you see some first classes in here teaching you guys. I would ask that, when they say, hey, we need instructors to teach the thirds, raise your hand, get in there and teach, and then encourage your younger sailors, the thirds, to do it for, the junior sailors. Because that's the only way this stuff's going to keep going. The team they've got is very small, but they're very dedicated. So if this stuff interests you and you're like a hardcore nerd, then please get on the team, because you know how it is in the Navy. We're losing, folks every year or so. So they're constantly, and the bigger, I imagine they make their team, the less work they all have to do individually. Because I can tell you a lot of hours have gone into this. So again, thanks for everything you guys are doing. Thanks for being here. I'd be curious, for those of you that have been here before, do you feel like it's gotten a little bit better? It has? Okay, that's the goal, right? Always make it a little better than last time. And if you guys have any recommendations or anything, the team is definitely open to suggestions. They're just trying to make it better each time. So, anybody have any questions for me? I doubt it. Just the old guy in here running my gums. All right. See you later, internet world. I'm just going to go sit in the back and hang out and watch you guys for a while. All right. Bye.
Alan, you ready?
Yep.
Yeah, I'm fine.
Yep. What are they doing the third going second?
So the next one will be the 22nd through the 25th of January, and then February 2nd, 3rd, 4th, and 5th, I believe. But I'll put that out before you guys go. I'll get the flyers.
Alright, we're gonna get started. This is the Aquarium Manual, Chapter 22, H1 Allen again. You gotta fix that.
Here's from Johnson. Here's the arrows on the keyboard that it should work though. Probably just the arrows.
I did work though. Let's put it out. Yeah. I'm saying it works now on this one. I was trying to use this. Alright, so hospital aquarium may encounter patients who've been exposed to poisoning or drug overdose. Patients initially present with no symptoms or having various degrees of intoxication. And basically this is going to kind of explain to us what to do, what poison is, what toxicology is, the science of poisons, what they do, how to detect, treatment. Next. So we're going to discuss assessment and treatment first. Assessment and treatment of patients is more important than effort to identify and treat the specific poison. So supportive therapy, managing ABCs and treating signs and symptoms is effective in most treatment poisonings. So there's going to be 6 steps in the initial evaluation and follow-on management. So you stabilize with the ABCs, you evaluate once they're stabilized, prevent or limit the absorption, so decontaminate, you flush the eyes and whatnot. You eliminate the enhancement, so with activated charcoal, for example, hemodialysis, hemoperfusion. You administer specific antidotes. If you already know what it is, this less than 5% of poisons has specific antidotes. So if you don't know what it is, you if you know it, then you go ahead and administer it. And then continuing care, dispositions, observe, and educate. So if it happens again, we know what to do quicker. General treatment. Once poisoning has been established, the general rule is to remove as much of the toxic substance from the victim as possible. The types of introduction, it can be ingested, inhaled, absorbed, and injected. So on the test, when I took it, it would ask it in a way to where what would it mean to be absorbed or inhaled, like different ways. So inhaled would be like oxygen ventilation. Absorbed is usually through the skin. They would list what it was, and you would have to pick, what kind of how it was basically absorbed. Next. Okay, injected poisons and envenomation. So we have the bee, wasp, fire stings account for most of the poisonings. So a small percentage can cause severe allergic reaction. We have scorpion stings. There's 40 species. The most dangerous are found in North Africa and India. The duration of symptoms is less than 24 hours. The scorpion sting, I did see that when it said on my test. It did say the symptoms, how long do they last? And it would have different hours, and they would say like 2 days or whatever. Spider bites. Most spiders in the U.S. are harmless with several exceptions, the black widow and the brown recluse. And bites are serious but rarely fatal. Next. Snake bites, and poisonous snakes are found throughout the world, and there's 5 venomous families. Now I might say them incorrectly, bear with me. The Viperidae includes the rattlesnakes, moccasins, vipers, bushmasters, adders. Death results mainly by coagulopathy and shock. Has anybody seen like on YouTube and stuff where they have like a little, like it looks like a shot glass of blood, and then they take the snake and then they have it like inject it into the, did y'all ever see that? That's something good to look up online if you haven't already. And it kind of shows you what the venom does when it's in your, when it gets into your blood. It immediately coagulates it, and it's this big old fat blood clot like seconds after. Something good to look at there. And then you have the cobras and mambas, and those are from neurotoxic venom. And sea snakes, neurotoxic as well. There's also some non-venomous species. Let's see, the vine, the twig, the bird snake. The venom action varies according to the type of snake. And then we have the mole viper, the stiletto snake. I like the name of that one. And adders. So venom action varies according to the type of snake, of course. So you're looking for signs and symptoms. Unless positive identification of snake occurs, consider all bites poisonous. So you have a visible bite, which will have the rapid swelling, you'll continue bleeding, rapid pulse, progressive weakness, blurred vision, nausea, vomiting, loss of consciousness. All right, next. So here's the treatment for the snake bite. You're going to try to identify the snake. Wash with soap and water. Certain suction extractors work if used within the first 3 minutes. Place the victim in a comfortable position. Remove the jewelry. Why would you remove the jewelry? Right. Start an IV. Why do you think it's important to start an IV? As soon as you can. Right, because, I don't know, your veins might collapse. It might be harder with swelling. Monitor vital signs. Apply a bandage 2 to 4 inches, it says towards the heart above the bite, and splint the extremity to a level below the heart, so do not elevate. And then transport, hospitalize, and observe for 24 hours. Alright, so bites, stings, punctures from sea creatures. A number of sea creatures are capable of inflicting painful wounds by biting, stinging, or puncturing. You have the stonefish, scorpionfish, the zebrafish. They've been known to cause fatalities. but we do have available antivenom. The stingray. Initial injuries, painful, penetrating punctures. Secondary wound infections are common and cause systemic signs and symptoms. And the colinterate. Hazardous types include the Portuguese man of war, the sea wasp, box jellyfish, and rosy anemone. The most common is the jellyfish sting. Anaphylaxis can occur from stings, and antivenom is available to neutralize the effects of the sea wasp and the box jellyfish. The octopus bites from the blue-ringed octopus can cause envenomation and lead to symptoms of muscle paralysis, vomiting, respiratory difficulty, cardiovascular collapse. There's no antivenom for that. Has anybody seen that one? I watch a lot of like nature shows and stuff. It's a really pretty octopus. Usually the pretty animals are the ones that are like poisonous. The cone shell should be considered as severe as a poisonous snake bite, and it has a 25% mortality rate. No antivenom. Sea snakes, 2 to 10 times the toxicity of a cobra venom, and because of the small jaws, the bites do not often result in envenomation. Next. Alright. So now we're switching to drug abuse. And drug abuse is the use of drugs for purposes or in quantities for which they are not intended. So even if they were prescribed to you, you're not using it like the dosage says you should. When abused, therapeutic drugs become a source of poison to the body, commonly associated with the use of illegal drugs, but it can also be due to prescription medications. Next. Alright, so central nervous system depressant intoxication. So opium and opium alkaloid intoxication. And it includes the most effective and widely used painkillers in existence. Commonly known drugs are morphine, opium, heroin, codeine, and methadone. The signs are coma, respiratory depression, restlessness, dizziness, lethargy, and scars from the injections. For alcohol, it's the most widely used drug. And individual withdrawing from alcohol are greater risk of serious complications or death than those withdrawing from narcotics. Has anybody ever seen alcohol intoxication? Yeah. Alright. Barbiturate intoxication. Unlike narcotic withdrawal, barbiturate withdrawals is life-threatening. And non-barbiturate sedative, not like benzos. There's a higher margin for safety overdose, and addiction require longer doses, and addiction requires longer period to occur, and withdrawal is particularly harsh. Amphetamines, commonly abused and are referred to as speed or uppers, can be taken orally in IV or smoke. Stimulants are highly addictive. We have cocaine. Although classified as a narcotic, it acts as a stimulant and is commonly abused. The effects are shorter, and overdose is possible, resulting in convulsions and death. Next. So mind-altering drugs, we have hallucinogen intoxication, cannabis intoxication, inhalant intoxication. So for the inhalant, abused by sniffing, bagging, cannabis intoxication up to 4 hours. That's something you could know. Alright, next. So, how do you manage them? You observe ABC and then the D&E, expose, watch or shock, and to give appropriate treatment. And if the patient can't be aroused, place in recovery position. All adults in altered mental status should be given oxygen. If recommended by the medical officer, place the patient on a cardiac monitor and get specimens. Empty the stomach if they're conscious and the drug was recently taken. And cardiac monitor all patients with altered mental status and prevent them from self-injury and transport to medical. Next. Do you have any questions? Let's go on to the next one. Can you go to the next?
Yeah.
Alright, chapter 23, medical aspects of chemical, biological, radiological warfare. The history of chemical agents. First large-scale use of chemical agents was World War I, 1915. The Germans used chlorine gas. With 5,000 casualties, one-third of the casualties in conflict were due to chemical agents. 1983, the Iran-Iraq War, mustard gas in 1984. 1995, terrorist group in Japan, and it was in a subway, 5,000 casualties. Next. Your overview. Chemical weapons are identified as any chemical which, through its chemical action on life processes, can cause death, temporary incapacitation, or permanent harm to humans or animals. Alright, so chemical agents can be dispersed by several methods. Aircraft, musicians like rockets, commercial sprayers, smoke generators. Chemical agents enter the body via respiratory and through the skin. The classes of agents are non-lethal, lethal, persistent, and non-persistent. Next. Alright, so the names, classes, and symbols of the chemical weapons. So there's the classes: blood, blister, nerve, riot, and pulmonary. And there's the symbol for them. Here's a chart. And just be sure to look over it. Detection equipment. You have the N9 chemical agent detection paper, and it indicates presence of nerve or blister agent by turning pink, red, brown, and purple. So I've seen it two ways for this one on the exam. I've seen it where it'll say, you know, what it was, and you have to pick what it is, and the answer would be nerve or blister. And I've also seen it to where the presence of a nerve or blister agent would be indicated by, and then it would have, like, your choices are, you know, pink, yellow, that. So. And the M8 chemical agent detector paper used to test presence of liquid chemical agents, and it's yellow, olive, and red. And so the yellow and gold is for the G class, and the Verdana green for the VX. So, and then blister agents. The N25 6A1 chemical agent detector kit. It detects nerve gas, mustard gas, cyanide. The kit contains the M8 paper instructions, vapor sampler, and the reactions on the paper that detect chemicals take 15 minutes. So that could be another one on there. How long does it take to detect the chemicals? It's going to be 15 minutes. Next. Personal protection. Joint Service Lightweight Integrated Suit Technology, JLIS. Filled M40 mask with hood, gloves and boots, mop levels. That's the table for the mop levels. N291, the skin decon kits. So decon within a minute, and the detailed use is in the NavMed right there. So you should have that slide to look over. And when you see it on the test, it's going to say, what mop level would you have this, and this item on? Then you just pick the mop level. I've also seen how many mop levels are there. Next. Chemical agents. So you have your nerve, and those are the symbols for them. The greatest concern, produce effect by interfering with transmission of nerve impulses in the parasympathetic nervous system, and they react with cholinesterase, chemical in the body that catalyzes neurotransmission. It's odorless, colorless, liquids or vapors. The onset symptoms within seconds or up to 18 hours. And these are all your symptoms: rhinorrhea, loss of consciousness, convulsions. The treatment. I have seen where they do ask for the treatment, and it's the atropine, 2 milligrams, 2-clam chloride, 600 milligrams, diazepam, 10 milligrams. It's the Mark 1 kits as well. And will be replaced by the auto-injector treatment, the nerve agent antidote, which would be 1 injector, 2 chambers of atropine, and 2 cam chloride. You administer intramuscularly on the thigh or the buttocks 3 times in 15-minute intervals. I have seen that. How often do you administer it? This is your answer. 3 times in 15-minute intervals. If the symptoms continue, administer atropine injections at least 5 to 10-minute intervals until the symptoms subside. These are your blister agents. They're vesicants exert their primary action on the skin. Those are symbols. Mustards are oily, colorless, or pale yellow. Lewisite is light to dark brown. The smell is similar to geraniums. The symptoms: pain, a gritty feeling in the eyes, photophobia, erythema, and blisters, typically 12 to 48 hours. There's no specific treatments. The British anti-lewisite, I've seen that one on the test. And wash away or use the M291 kit. The blood agents, they disrupt oxygen utilization at the cellular level, causing cellular suffocation. Hydrogen cyanide has bitter almond smell and evaporate quickly into vapors or gases. The symptoms: increased rate of breathing, dizziness, nausea, vomiting, headache. The treatment: the 2 amyl nitrate ampules crushed and inhaled up to 8 used, or IV sodium nitrate 300 milligrams to 600 milligrams. I've seen that one, the IV, the 300 to 600. And then IV thiosulfate, followed with 2 antidotes and half the dose is needed. Next. So pulmonary agents. Damage membranes in the lungs, separate the alveolar tissue, resulting in fluid from the blood, plasma leaking into the alveoli, causing hypoxia. Alright, so it has phosgene, chlorine, smoke, ammonia. So this is colorless and smells like fresh cut grass or hay. The symptoms: irritation of the eyes, nose, airway, coughing, tightness in the chest. No symptoms 2 to 6 hours post-exposure. So since it's pulmonary, you're thinking it's mainly going to affect your lungs and your passageway, right? So there's no antidote. Treatment is to remove the patient from exposure. Decon is fresh air and remove the clothing or rinse for liquids. Next. So riot control, harassment agents. They're relatively non-toxic, produce immediate but temporary effect. Crystallized solids dispersed as fine particles or solutions. Tear gases, vomiting agents. The symptoms are pain, burning, irritation. So we've kind of experienced this before, and it can last up to 2 hours. The treatment: you're going to don your protective mask, move to fresh air, like you would at the gas chamber. Next. Treatment of casualties: control hemorrhage, treat shock and wounds. Decon exposed eyes and skin, remove contaminated clothing. Then decon station organization. Here's a table. You should have it on your slide as well, so you can go over it later. And each should have a minimum of 2 decon stations. Next. There are biological warfare agents. They're used throughout history, like the plague, anthrax, ricin. The types of biological agents can be bacteria, viruses, toxins. Here's the examples from the chart on your slide. Difficult to determine if disease outbreak is natural or intentional attack. Indicators include unusual disease for area, restricted geographic distribution. There's no natural vector or a high morbidity rate. It's detected by a handheld assay panel. It detects presence in 15 minutes, portable labs in an hour. And you can use PPE in 40 masks. Next. Alright, so bioagents and their symptoms. Anthrax. Gram-positive, encapsulated, and pore-forming rod. They're cutaneous, pulmonary, gastrointestinal, so you can get it any of those ways. The average incubation is 1 to 7 days and up to 60 days. I've seen the incubation for anthrax on there. The symptoms are cutaneous, raised itchy bumps of vesicle into painless ulcer, necrotic in the center, fever, malaise. Inhalation, fever, headache, malaise, gives me a cough. And then gastrointestinal, fever, abdominal pain, tenderness, emesis and blood. Emesis is tinged with blood. And the stool may have blood. Next. The plague. You would have a gram-negative rod, non-motile, non-sporulating, confirmed in the lab. It can be pneumonic, so in your lungs, and your symptoms are the fevers, chills, tachycardia, headache, muscle pain. Treat in 24 hours or fatal. The bubonic, most common via skin, swollen lymph nodes, fevers, chills, headaches, malaise. Progresses to septic or pneumonic. Alright. And then blood perspiration, circulatory collapse, septic shock. And the incubation period is 1 to 7 days. Treatments are antibiotics. Next. And this is the tularemia, which is rabbit fever, gram-negative, non-motile. Let's see, rarely fatal, used in World War II. The types are ulceroglandular, most common from a tick or a deer fly bite, pneumonic, and typhoidal, and the result from intentional aerosol release of the agent. The incubation period 1 to 14 days. The symptoms are skin ulcer, since the word, the ulcero, pneumonic, and that's cough, usually with anything with a lung, it's going to be cough and chest pain. And the treatment, antibiotics. Next. Alright, so botulinum toxin, encapsulated, anaerobic, gram-positive, spore-forming, rod-shaped bacterium. Neuroparalytic, so muscle paralyzing. And 7 antigen types exist. Incubation period 12 to 36 hours. Signs and symptoms: cranial nerve palsies, yeah. Dry mouth, muscle weakness. The treatment is going to be travolent, antitoxin. All these, they're all prophylaxis. Next. Alright. Ricin is derived from beans of castor plants. They block protein synthesis that kills your cells. Delivers as aerosol ingestion. The incubation. Symptoms appear 18-24 hours when inhaled and death in days. Symptom of ingestion, basically like the other ones, nausea, vomiting, diarrhea, abdominal pain. Inhalation, within 8 hours you're going to have the cough, shortness of breath, fever, airway necrosis, and then death. Injection, less than 6 hours, weakness, muscle pain. The treatment, no known antidote. Next. Smallpox has been eliminated except as an agent of bioterrorism, spread via aerosol and mucous membrane transmission. Incubation, I have seen this one for smallpox. Incubation period 7 to 19 days, typically 10 to 14. The symptoms are flu-like, rash develops into scabs, and there's no treatment. Vaccine for prophylaxis and isolation is recommended. Next. Hemorrhagic fevers. Caused by 4 distinct families of viruses, all characterized by fever and bleeding. 4 families. You have the aerinovirus, that's rodent transmitted. Then another one would be the Marburg, Ebola, mosquitoes, ticks, sandflies, tick bites, and i.e. the yellow fever. You can call it that, I guess. The treatment, supportive treatment only. Yellow fever is only prophylaxis. Next. Radiological warfare. The history. World War II, first atomic bomb. A radiological dispersion device is a device that causes the purposeful dissemination of radioactive material across an area without detonation, or a dirty bomb. There's 2 modes of radiation within the cell, direct and indirect. Next. The types of particles and rays, you have alpha, emitted from the nucleus of a radioactive element, heavy, short range, not able to penetrate clothing or skin. Beta is injected electron, short range, light particle, moderately penetrating. Gamma and X-rays, electromagnetic waves, highly penetrating, and neutrons. So I've had a question where they tell the situation, and then those were my options. So is it alpha, beta, gamma, what kind of rays it was? Next. Units of radiation. The radiation absorbed dose, the RAD, is used to measure a quantity of absorbed dose radiation. Let's see. The International System of Units new terminology is the gray. Dose is the total number of energy absorbed per gram of tissue. There's your table. The rem is the unit used to derive the quantity of the dose. The SI unit of any quantities expressed is the dose equivalent, and lethal human dose is 400 to 500. Next. These are your measurement devices. And I don't know if you can see the picture of what they look like. So the first one is used for ground surveys. The one that's the 13th is compact and pocket held. And then the one that actually has a different one, it's not the UDR, this one's the PDQ. This multi-range device detects the beta and gamma radiation using that ionization chamber in 2 ranges. Next. Your exposure factors, time, distance, and shielding. Alright, so that'll obviously affect how effective you are. Like if you're in there for a longer time, it'll obviously affect you more. So your PPE is going to be chemical protective mask, your Tyvek anti-seize suits, and MOP 4. And this is the effects on your chart. Next. Acute radiation syndrome. Your symptoms: nausea, vomiting, diarrhea, malaise. That's your phase 1. Looking and feeling healthy and sick again. Seizures, coma, phase 2. Convulsions, ataxia, tumor, lethargy, severe diarrhea, decreased white blood cells, phase 3. The treatment: stabilize, decon, supportive care. Chronic radiation syndrome. Long-term exposure to low-dose radiation. The treatment for this too is just removed from the environment. Next. Radiation dermatitis. It's acute and chronic. It's prevented by washing off the contaminated material. Let's see. The symptoms: redness to the irritated area, hair loss, edema. The treatment, again, is removal from the radiation source. So if you'll just look over your chart here. And so your acute radiation, the most you get to is really the immediate skin blistering, and then with the chronic, it's where you have the cancer risk. Next. Keep it on the list.
Yep.
Going to 5-minute break? Yeah? No? Alright, we'll continue. Chapter 24. So before any emergency treatment is rendered, the coroner must follow the emergency treatment guidelines first, as listed below for every dental emergency. Okay, next. Diseases of tissue of the tooth. So dental caries, those are pretty common. And the treatment, you know, you dealt with dental before, so you know they just take off the debris. Acute pulpitis, inflammation of the pulp due to dental caries or trauma. I have seen on the test where they'll like list what it is, so it'll say like infection of the pulpal tissue. I've actually seen this one, and it'll have like 2 different kinds of abscesses, and you got to pick which one. So periapical abscess, that would be one of them. Alright, next. So diseases of periodontal tissues: marginal gingivitis, that's the inflammation of gingival tissue. And let's see, necrotizing ulcerative gingivitis, So it could ask you, like, what kind of gingivitis is this? And, you know, necrotizing is going to be severe because it's rotting tissue, right? Periodontitis, progressive loss of alveolar bone around the teeth, the periodontitis. The same treatment as the marginal gingivitis, and then the periodontal abscess, which you said is an infection of the tissues. Next. Diseases of the periodontal tissues, periocorn, periocorneritis, that's inflammation of gingiva, again, against the erupted tooth. And then other oral diseases, I've seen this word on the test, the stomatitis, inflammation of the oral mucosa. There's two types, the herpetic and the aphthous stomatis, so a canker sore basically. And it's painful swelling, blister, cold sore. And post-extraction hemorrhage, that's heavy bleeding from where they took out a teeth or something. Next. So, dry socket would be, I guess, considered an oral disease, and fractured teeth. And here's the pictures describing. Next. So, fractured tooth treatments, and there's 3 types. The first type, you smooth the edges, sandpaper strips, and then the second type, you isolate the area of cotton balls, dry tooth, expose dentin with zinc oxide, you instruct the patient to eat bland diet, avoid cold, sticky foods, remove the excess, instruct the patient to eat a bland diet. So you're going to do a crown for the type 2. Type 3, you're going to place a crown over the affected tooth. And if it's not enough tooth for a crown, use a splint. And it's supposed to show you a picture of the splint. Type 4, that's a root fracture treated by the dental officer. If not, splint like type 3. Next. Alright, so fracture teeth. All the foreman's going to do, you're going to rinse the tooth with saline and place it back in the sockets. And you've seen these before, right? The wraps around the head. Next. Cool. Last one for the foreman, right? Swing back. So, decedent affairs. The Navy's decedent affairs program consists of search, recovery, identification, care, and disposition of their remains. The overall manager of the decedent affairs program is the Navy Casualty Navy Mortuary Affairs located in Millington. Let's see. Alright. And this is the OPNAV instruction, you need to remember, 5360.1 series, decedent affairs manual. Next. Alright, decedent affairs 5 programs. So you have the current death program, the graves registration program, and the concurrent return program. Next. The return of remains program, they provide the permanent disposition of the remains of persons buried in temporary cemeteries, not able to be evacuated for the current return. Let's see. This looks like the last slide. Next. To be eligible for decedent affairs, there's the instruction for it. They have a manual, and it's for Navy, Marine dependents. And notification of death within 4 hours after submit casualty reports to the MilPERS. The CO must submit it. So within 4 hours might be on the test. And then the personnel casualty report should be sent by priority message with the following activities. These are the people in it. Next. Notifying next of kin. And like I said before, I've seen it on the test where I ask you during what times can you contact the next of kin. And CAICOs are assigned for a period of 90 days to 9 months, depending on the needs of the families. Next. Autopsy, performed on active duty and active duty for trained personnel. And they are performed if the death is considered accidental, intentional, suicide, homicide, or absent care of physician. Let's see. The manual of the ManMed states that when an aircrew member dies while serving as an aircrew member on military aircraft, the medical officer will recommend to CO that the autopsy be performed to determine the cause of death. And the autopsy is not mandatory but requested, incorporates in the disposition instructions. That's what you would write, in the interest of medical science to confirm diagnosis, etc. Next. Let's see. So this JAG instruction 1800.7 series requires a convening of a fact-finding body when incidents of nature occur. It's bold, so somebody's seen that on the test before. Continue. Right. Procuring mortuary services, that's your AppNav instruction. And I have seen where they ask you for your primary expenses, so pay attention to this part, the embalming, autopsy preparation, hairstyling. Next. And your secondary expenses. And it'll list it like that. They'll list what the expenses are, and they'll say is this primary or secondary. Alright, next. The initial prep. Remains should be refrigerated above the freezing point 36 degrees to 40 degrees. Overseas, it's outlined in this instruction. And I have seen where the certificate of death is 3 signed copies of the DD form. Certificate of death overseas must accompany the remains. This casket sizes 18 gauge silver tone metal sealer and the standard 23 by 78, and they have an oversize. Next. Questions? Nope.
Take 10. No,
She's got
take
one more.
5. Take 5.
She's got one more.
Yeah, she's got one more, but he's gonna finish the form manual. She just take a quick 5 while I pull these other ones up. Yeah, you're not gonna see it. It's just there to put people in. Your last one, or you want to do this?
You choose like the worst one.
I was just looking at the list and like,
There you go. Fucking storm? How did you
that was like 400 for 2 of the chapters, or 100 pages each. And they were on like,
How's my
just like, there's not gonna be anything. It was like very like, it was very specific to each type of watch, and I was just like, if they pull a question, they're gonna know, sure, so be it.
Is that what you were asking? You had,
Yeah, so that one, if you search, I said, is it current? Because if you search it, it doesn't come up. It comes up as like 4 tag 1 1. So that's why I'm wondering.
That's what he did.
No, 35.
Yeah,
Yeah, but it's the same instruction you
Well,
did.
we only did like a chapter.
Well, it's only 2 chapters in that
Yeah,
one.
this one's different chapters. You said 5 and like 8 or some shit?
Yeah.
Yeah, I think we only have chapter 1.
How's that safety one, the 5100.19 should be good. I had to add hearing to it, so if you go in there and look at it now, you should have the hearing conservation stuff.
Okay, cool.
So we made it out on time for lunch. Now we're pushing back past the end of the day. Can't win in this stuff.
Because if you
Yeah, field hygiene.
so this one isn't. It's like it's the same number, but 0.1, which is.
Hey, we're gonna go over this one real quick, and then we'll finish up the last few form manual.
This is only like 6 slides.
Should be quick.
We got this.
Not quick. Give me a minute to come back real quick.
Was that many gone?
How many people stepped out? Like 3?
Yeah, there's only like 2 or 3 missing.
On this, this season of affairs? You don't know. How many, you know, that's about how many I got right.
Make sure you guys look over that decedent affairs instruction. I know going from taking the first class exam, going from like second to first, that was the biggest thing that, yeah. That guaranteed probably like 15 to 20 questions. Especially knowing like the size of the caskets, all that stuff, basic stuff.
Who runs what,
Yep.
time frames, and
3 certificates from overseas in 2064, 2063,
the
all those
primary,
different stuff.
primary, secondary, all that.
Yep, exactly. How long if you can have a layover if you're the KCO, the person that goes with the family. Right. So, we'll go over all that stuff. I always read that the night before the exam, honestly.
The senior affairs used to always be that one, like in all the other exams, and it's kind of chalked up as the loss.
Yeah.
But for the E5, for the E6 exam though, it's like, there's so much more of it that you can't.
Well, now you know the other stuff so well.
Yeah.
You gotta guarantee yourself that you won't ask any questions.
Yeah. That was the anatomy and physiology.
Yeah.
Oh, was it the chief in the beginning?
No.
Here's if it's comfortable.
It was an IDC stuff there.
It was,
Arcera.
yeah.
Salad or something.
Alright, here we go. We're gonna go over this one real quick.
Alright. Next.
Okay, we're not gonna get over it. No, we got to go.
Alright, so the purpose to update guidance on the radiological safety management of all imaging systems in the Navy. So basically this is what this instruction is, and it talks about the radiological systems performance evaluation program. So of course, like all the other ones, is the standards, reporting procedures, everything else. Next. Responsibilities. Navy Environmental Healthcare Center. They approve, maintain, distribute the references. Next.
Hey, that big one at the bottom right there. Navy Medical Logistics Command will notify command and facilities receiving new and replacement medical radiological systems. Alright, within 10 working days. You know that. So they handle all your x-ray machines.
Training officers, they ensure a qualified surveyor evaluates radiological systems performance. All radiological systems shall be evaluated within 30 days of installation and after major repairs, so 30 days. Ensure medical x-rays, units, fixed or mobile, ashore and hospital ships are evaluated annually. It's going to ask you how often, annual, for this. Let's see, all other fixed x-ray units for float require 24-month evaluation. And deployed units may delay the unit evaluation until they get their home port within the 24-month window. Maintain all system evaluation reports for 3 years. Qualified surveyors who have oversight of the commands within the area of regional responsibility. They provide a summary report of each evaluated radiological system to the responsible commanding officer within 30 working days from the completion of the survey. Qualified shield designers design radiation structural shielding following requirements A and B. And they provide completed shielding design and request authority within 30 days of receiving all applicable input data. This is a form. So that is the equipment survey fund.
Sorry.
There you go.
I think that's it.
That's it.
Any questions? Pretty straight, nitty-gritty. Probably 2 or 3 questions out of there, so understand view med instruction 6470.22.
Alright, guys, we look on your side. Hopefully,
Alright.
At this
More
point.
like haters on me, really. See you later.
Yeah, at this point, you should have.
You got,
Did she take my phone? I think it's right there.
okay. You got 12 minutes.
I got 12 minutes?
4 fucking seconds.
Okay.
Side wasn't for it.
18, 19,
Oh, I know.
The worst fucking thing.
I mean,
Or the worst four.
what bogged us down was the house guy. On the spot.
At this point, it's
44 slides.
Alright, here we go. Chapter 18.
Alright, so I'm H1 Glory. I'm not going to read each slide line by line. I will pinpoint the important stuff and then inform you of, I guess, extra tips on what to study and look out for. That's actually going to be beneficial for the exam. Good to go? Alright. So pharmacy is going to be a little dry, but we'll skim through it. So pharmacology, basically the study of pharmacy. Pharmacognosy is basically the biological breakdown of pharmacology, so your natural meds. So Indian medicine, basically, think about it. They did natural stuff to treat symptoms, stuff like that. Next. Posology is basically the dosage of your actual dosage, what you're giving. The yeah, that one. Okay, so living organisms. So basically think of the effects on you're giving an antibiotic, on how it affects that particular bacteria. It's breaking it down, killing it. It's not going to work on a virus, so based on that particular organism. When it comes to the pharmacotherapeutics, basically the treatment. So think of, you have high blood pressure. If you take this medication, it's going to help with the treatment to lower that blood pressure. Toxicology, basically poisons. Therapeutics, basically treating the disease. So basically, just like I stated before, you're going to give this medication to treat this type of disease. You're not going to give doxycycline to treat asthma. All right, the Remington is the most used textbook. It's basically on every single exam, so just remember the Remington. It is also known as the Blue Bible. All right, minimum dose. Common sense. Minimum dose is the least amount of medication you have to give to accomplish your goal. Maximum dose is the largest amount that you can give without making it toxic. So you can only take so much Motrin before it actually starts becoming toxic within the body. Toxic dose basically is right above the maximum dose. Now it's toxic. All right, therapeutic dose. basically the combination of minimum and maximum dose is basically the amount of dose you need to complete your task. Minimal lethal dose is basically the amount of medication that will basically kill you. So morphine, give it to a certain amount and then it's going to kill you. Alright, the most common factors for pharmacology. Age, so easiest concept for that if you're thinking, is it weight or is it age? Children's Tylenol, do you take it? No. If you're older, you're going to take regular Tylenol. So it's basically going off by age. Next one is going to be off of, and then the calculation, years divided by age, plus 12, and then about the dose. The next slide should be the, yeah, no, that's fine. So if you got, I don't get 260, I believe I get 130. I've asked a couple pharmacy techs the same thing, and they've got 130 as well. So
I don't think this slide is right.
I don't think this slide is correct.
No Young's rule. I'm sure all you guys have heard of that, right? We've had it beating our heads forever and a day. Young's rule.
It's usually not even on the exam anymore, this higher up anyway. Next slide. Alright, weight, Clark's rule. So basically, depending off weight. So if your kid's larger compared to the normal kid, it's going to go off that weight and how much you're going to give. Same thing when it comes to anesthesia. You're a 400-pound person, you're probably going to get more anesthesia compared to like a 150-pound person. Next. Same thing. Alright, factors. This doesn't really come to a factor. Alright, types of types of giving medication. So you have oral, swallow your pills, sublingual, underneath the tongue, buccal, from the cheek. Alright, parenteral, basically injections. So subcutaneous, so that's going to be like your mosquito bite shot for your PPD. Your intradermal is basically your most common way of getting shots, so like your flu shot. Next. Alright. IM. So just like again, basically the same thing, different type of, and just depending on how they're putting in the muscle. Intravenous, IV, and then intraspinal is basically what's going through the spinal column. Next. Inhalation, so this is basically you're breathing in the medication. So you have your nebulizers, your gas inhalation, and vaporization. Alright, topical, common sense, it's your lotions, your acne cream. It's basically going on the skin and it can go absorb through the blood system that way. Rectal, it's going up through the anus, and then vaginal, going through the vagina. This is just good to know. It's never on the exam. Alright, chemical name. So I have seen chemical names on the exam. Don't worry about it. You're never ever going to know what the chemical name is unless you're a pharmacy tech. Basic ones you're going to know is either genetic, which is basically always on the exam, and then brand name is what it's just known by. So generic name, ibuprofen, a brand name, Motrin. So chemical name is that. You're never going to know that. And then I guess Viagra, whatever that is, to make that medication. Alright, your astringents just makes the skin shrink. Emollients, basically your lotions, so it makes fatty oil. Expectorants, so like your Mucinex, it's basically the cough up the phlegm. And just before I go in depth with these, so for these medications, it's good to know what they do. Obviously, when you see the exam, it's really case-based. So my recommendation is go over what they are, so like astringents for shrinking, and then there's more examples on like what they are, like medication-wise, so like Mucinex and expectorant. Jesus. All right. Just read up on like treatments for these types of medications. So like, okay, I have a sore throat, or if you have diabetes, like look up certain types of medication and like treatment-wise, because it's good to know that an expectorant is for therapeutics. But when it comes to exam, they're going to give you that case study, and you're not going to know what it is. So basically, the best idea is to look up treatments for particular medications. Make sense? All right. Next. Antitussives. So the way I always remember it, kids are always fussy when they start coughing when they're sick. So antitussives for coughing. Nasal decongestants, your Sudafed, reducing congestion inside. Antihistamines, Allegra. You have your Benadryl. It helps with allergies and stuff. Next. Alright, your antagonist, basically helping reduce the acid inside your stomach, where the antacids are, the acid's already there, it just helps break it down more, where this basically helps with the histamines, it helps prior, so you don't get the symptoms, where this is you're already getting the symptoms, and it's helping to break it down while you're having the symptoms. Make sense? Or am I confusing anyone with those two? Alright, next. Antiseptics, germicide, disinfectants. So the best way I can break this down, just think of washing your hands. Antiseptics basically help suppress the growth. So you're washing hands with just water. Basically, think you have mud on your hands, you're getting it off for the most part. Germicide, you're actually washing with soap. It's killing everything, but doesn't kill everything fully. Whereas disinfectant is you're washing your hands with soap and water, and then you're using like sanitizer and killing everything. Next. Alright. Sulfamides, they're effective against gram-positive and gram-negative. So this is where I was getting, for example, so look up Bactrim and Septra, and just look up what are some treatments that they can be used for. So that's something you can do like WebMD, whatever, and just like just look up that drug and be like, okay, it can treat for this or this. Penicillins, like amoxicillin, everyone knows it's one of the best ways to kill antibiotics and stuff like that. Next. Cephalosporins, you have your K-Flex, just another version of penicillin. So if you're allergic to penicillin, most likely you cannot give this. I've seen that on the exam a few times. Tetracycline, your doxy, your minocycline, it just helps with the polypeptides. So like I was saying before, like most people wouldn't know what doxycycline or minocycline is unless you're prescribed it to yourself, or if you've been like deployed and you got it. So a lot of people, okay, doxycycline, it can help against STDs. Some people that never knew before, that you can actually use that. Or you can use for malaria. Everyone before is like a malaria, Primaquin. So that's the reason why I say look up the medications for treatments. Next. Alright. Anginucleosides, I've never really seen the protein synthesis for gentamicin. It's basically just your macrolides, your erythrocyan, vancomycin, so that's for your gram-positive cockeyes. Keyword, the gram-positive. Next. Alright, antifungals, help suppression of fungus. Antiparasitics, against parasitics. Anti-malarial, there's again, like I said, Primaquin, anti-against malaria. Common sense. Next. Alright, laxatives, helps you go to the bathroom. I'm live, I have to keep my language. Alright, diuretics, basically let you go urinate. Next. Alright, so your non-narcs, helps relieve pain, Tylenol, anti-pyretics, your anti-inflammatories, say your Motrins. So a lot of this stuff is starting to repeat stuff you haven't noticed. Next. Your stimulants and your depressants, so your stimulants like your Ritalin, your depressants, your barbiturates, so drugs a lot of people know, you do your downers and your weed and everything, it's like considered like a depressant, your stimulants, consider like cocaine and everything, makes you all wired and all. Alright, opiums, your morphine, codeine, your psychotherapeutics, your Valium, skeletal muscle, so your flexural, next. Cardiovascular, your ammonite, so when it comes, you see this a lot, the reason, you can read it right here, when you're having your nerve agent, you're getting the atropine, this is supposed to counter-effect that because it's going to ramp up your heart so much, so the amyl nitrate actually like counteracts that, so your heart doesn't go into like heart failure. Vasoconstrictors, epinephrine, anticoagulants, heparin. That's the main one I see is heparin, like heparin drips. You're on a ward or anything. Next. All right, so your vitamins, A, DEC, those ones are fat soluble. The main ones I see on here is your B vitamins. So if you see B2, know that's riboflavin, B6, pyridoxine, example like that. So I've seen that all the exam multiple times. It's usually one of the B vitamins that they're asking for the other name for. Next. It's not important. Next. Elixirs, basically it's mixed up concoctions. Same thing with suspensions. Main thing for suspensions is it's reconstitute. So they have the main one that's known in wards are cocktails. So they have like the lidocaine and some other cough syrup in that to help with basically the same thing. Next, ointments. Just basically think of your fat soluble like your lotions, but it's more of a liquid form. Suppositories, basically going up the rectum again. Capsules. So your gel, so think you're taking your Tylenol, your gel tabs, that's basically what that is. Next. Alright, parts of the prescription. So the main thing you have to know is this section right here, the superscription, which is actually the whole thing, the whole prescription. The inscription is the name and the quantity, so I'm getting this type of medication and this much. The subscription is basically the instructions to go to basically the pharmacy tech. And then the signet is for the patient, this is how you actually use this medication. So the main thing that's going to be for the patient is the signet. Everything else here is for the tech. And then obviously it is null and void unless it has the prescriber's signature on there. Next. That's an example. Next. Alright. Your schedule 1, 2, 3, and 4. So schedule 1, basically never ever used. Your heroin, your cocaine. Your schedule 2 is your barbiturates, so like your morphine. Your schedule 3 is going to be like your Ritalin. Schedule 4, your Valium. Schedule 5 is basically almost everything else under the sun. That's pharmacy.
I know the prescription form is the last one. 1289.
Okay, yeah, so the 1289 has been,
Oh,
fully formed.
How many vectors?
Have any questions on pharmacy? Hope that was fast enough for you guys. Alright, lab. I was actually a prior lab tech, so I saw some stuff that's not on these slides, so I'll give you a little extra stuff that's not on there that I know I have seen on the exam before, that may help you guys out.
That child dose was wrong because they had 3 divided by 3, and that's 12 is supposed to be 3 divided by 15, so you're supposed to have that 3 on top of the 15.
Yeah.
And then that'll come out to 0.2, and you multiply that by the adult dose, and that'll give you child dose.
Because I was looking at it, I was like, it's wrong.
Yeah, it just goes next year. There's an extra.
The lab form is the 550. That's for the urinalysis. Next is the main one. Should be 545. Next. Just so you know, they never use those anymore. That's old school forms. So blood collection, 15 degrees. Tourniquet's going to be 2 to 3 inches away from the site. Next. It's basically what it said right here. It's good to know, always label a specimen, but that's never going to be in the exam. Don't leave the tourniquet on there more than 1 minute. I have seen that. Next. Alright, so for the finger procedure, I have seen this. They'll ask, like, what is the actual proper technique? So you're actually going to poke. The best way I was always taught is super fingers from Dane Cook. So your middle finger and your ring finger is the 2 fingers that they request you to do. So you're just going to do the side of the finger, poke on it, squeeze, let blood pump out, wipe it, so you get rid of that tissue fluid in there, and then actually start squeezing and then getting your blood from there. Next. Alright, so for the microscope, this is basically the main breakdown of it. The main ones you have to know are the stage, the iris, the condenser, I guess the stage and the base, or the arm. Basically, the arm basically just connects the eyepieces to the base. The stage actually holds the specimen on there. The condenser basically controls the light, and then the iris controls the flow, which will go in detail next. So arm holds everything. Next. So the main two I particularly see on the exam is either going to be the condenser or the diaphragm. So the main thing for these is the condenser. If you ever looked in a microscope, it has the ability to either make it a large amount of light that goes in there, or if you control it and move it around, it will basically make it a fine point. So think of your pupils dilated and then constricted. Basically that it controls the flow of light on how much it's going to go to see the specimen. Whereas the diaphragm, it basically kind of, think of sunglasses. It basically just puts like a certain amount of restriction on the light flow. So some specimens you can't really see under a certain amount of light, so it just helps you fine tune it. The main other thing, oil immersion is always going to be 100. However, oil immersion is basically only going to be in microbiology. Everything else is most likely going to be under high power. Next. Alright, your complete blood count, also known as your CBC. Basically your red blood cells, your hemoglobin, hematocrit, white blood, and then your differential count. One thing that I have not seen on here is the different types of blood cells. So you have your monocyte, which is the largest. You have the most common one, which is neutrophil, which attack bacteria. That's the reason why it's the most highest. We fight bacteria every day. Next one's going to be your lymphs, which basically attack viruses. Second most thing we fight off of. EOs, which fight off.
It goes into.
Goes into? Oh, go here. Right. Your hemocytometer. This is old school. This was just another way on how to read blood counts. This basically was old ship technology stuff here. For the only thing you really need to know here is the adult and newborn, male and female dosing for blood counts. So male is 42 to 6, female 36 to 50 or 5.6, newborn. Just remember, newborns are always going to be higher than everyone else because they're still growing, so they need that extra blood flow. That's for red blood cells and for white blood cell count. Next. So, like I said, for the hemocytometer, basically you would just read the blocks and you would just go in order. And you would just get a number, and that's how many blood cells and everything like that. Next. Alright, so hemoglobin and hematocrit. So the main thing that people get confused on is the percentage, and this should not have a percentage here. So this is the percentage, this should be microliters. So for hemoglobin is basically how much nutrients are in the blood itself compared to where the hematocrit is basically the blood volume and how much is actually in the body. Next. Alright. Main thing on this then is for the amount. So adult 4 to 11, children is 5 to 15, newborn 10 to 30. Leukocytosis is basically the increase of white blood cells, where leukopenia is the decrease. And just know that the different types of diseases that fall in there. So I have seen examples where, okay, meningitis falls under what type of disease, you're going to say leukocytosis. So, next. Alright, so here's the white blood cells. Next. Alright. So here we go. So the EO, they basically fight off parasites, vasos, basically fight off inflammatory. Limbs fight off viruses, monos fight off fungus infections, and neutrals basically neutrophils. Don't get confused. I know a lot of people monocyte basically fights off mono. No, it's going to be limbs. So I know people ask me that, it's lymphocytes. Another thing on here, red blood cells are known as erythrocytes, where lymphocytes or white blood cells are known as leukocytes. Next. Shift to the left bad, you're basically dying, but there's really nothing else on here that's important. Next. Alright, so for here, main thing you need to know is the temperature. So basically the way I always broke this down is think polar bear plunge. They're basically psychos that want to go in cold temperatures, so they thrive in degrees under 4 degrees. Meso, I think, in medium, so they're the middle ground guys. They like regular body temperature at 35 degrees Celsius, and then thermo, always meaning heat, they like it 42 degrees and higher. For aerobes and anaerobes, aerobes like oxygen, anaerobes don't like oxygen. Coxes are spears, bacilluses are rods, weight and spirochetes are screws. So basically, how I always was taught this in lab tech school is think of the opposite effect. So you see coxes, think cock and balls. So you see a cock is going to be the opposite, these going to be balls. You see bacilluses, you're going to see balls, next is going to be the rod. So the reason why I bring that up is because they always have, was it gram-negative bacilluses, cockeye, whatever, and they'll ask, what does it fall under? And there's a slide on here that's coming up next on the breakdown of certain organisms, like bubonic plague or staph infections. They'll have it on what's a gram-negative, gram-positive, and that's where that falls into effect. Next. So this is what the slide I was talking about. So like I said, the cockeye, positive, negative. So you have your negative, your gonorrhea, or your meningitis, and then your positive, your staph, your strep, your bacillus, positive, negative. I'm just going to go off the ones I know I've seen on there most. You're going to have your Yersinia pestis. It's really the main ones I've seen on those. So, yeah, these ones are basically the ones that are usually on there, and then for the bacillus negative, it's usually just Yersinia pestis. So for your gram stain, crystal violet is the primary stain, gram iodine is the mordant. So I've seen it asked both ways. What is the mordant? It's going to be the gram iodine. What is the decolorizer? It's going to be acetone. What's the counterstain? Saffron. Just go off. These are not real life, but just remember 1131. Don't get confused. So the main stain, most people know, is crystal violet. This is for gram stain. The other stain that's asked on the exam is right stain. Right stain is for CBC counts. Next. RPR. It's usually, for some reason, always on the exam, and it tests for syphilis. Usually that's what test for syphilis, and it's going to be an RPR test. KOH basically tests for fungus. So wet prep. So if there's like females come in with a yeast infection like that, that's basically the same exact thing. They're testing for the yeast or fungus. Next. Alright. Your analysis, basically just know the averages. So 6 to 2,000, but the average is typically 1,500. First morning void is the best one. Is the main reason why they like it the most, particularly with pregnancies, because you basically slept the whole night and you have all that sediment in your urine, so it's going to be concentrated the most. Just think about it, you pee more of the day and just more and more is going to come out. That's the most buildup that you had throughout the whole entire day. Next. These are different types of colors for your urine. The main one that I've seen on here is going to be orange, and it's usually for iridium. If you ever use it, the lab's just going to take away your and it's null and void because it basically stains the whole entire shit. You can't use it. Next. Specific gravity, just know the 1.01 to 1.60, and typically the normal is the 15 to 30. I think I've seen that in almost every single exam. Next. Oh, I'm sorry, go back one. What they may ask is, what did it use to check the specific gravity for urine? And it's going to be the refractometer. I've seen that on the exam multiple times as well. Next. Not that important. Next. Alright. One other thing that I noticed that wasn't on here is the two colors. So you have the red, which is basically nothing in there. Anticoagulants will be your green for heparin, your blue for sodium citrate. Green is, say green heparin, gray is sodium fluoride, just like your toothpaste. And then your purple or violet or pink is going to be your EDTA or ethylene diamine tristic acid. The main ones I usually see on there is probably heparin, which is the green tube. The other thing on here that I know that wasn't on there, urinalysis test kidney function, where chemistries are typically liver testing. So they'll ask you, you're getting a lab test for a CMP, what is it testing for? And it's going to be testing the liver. If you're getting urinalysis, what is it testing for? It's testing for kidney function. And then the most common labs that are ordered are CBC, CMP, and urinalysis. I've seen those on the exam as well. All right. The next two chapters are go together. It's basically emergency medicine.
You gotta be out here by 16:30.
Yeah, I'm going to speed it up. There's not much on this.
I'm not saying you're going good. I'm just letting you know. 16:30. You guys will have to review it on your own, or we'll pick it up tomorrow in the morning.
Alright, so for these, basically just know your bandages. Barton bandages, basically for the lower jaw, that's particularly the one that I've seen the most. That or the triangular bandage for basically if you have a splint or whatever like that. Next. We use CAD tourniquets, but this stuff's never usually on the exam. Next.
You guys know all this. Normal
Saline. Basically just to get fluids in there, lactate ringers basically for trauma, and head starch basically to get the plasma blood volume up. Next. Main thing for the, just go back more. The lactate ringer, the main times I've seen it is for burn injuries. So if they're asking what type of IV solution you want to give for a burn victim, it's going to be lactate ringers. I've seen that exam a lot. This stuff's never in the exam. Next. The only thing I've seen you really know on this slide is the oral or nasopharyngeal, and the main difference is which one you're going to give to a conscious patient. You're not going to give an oral, you give a nasal. That's really the main difference. Next. The litters, the main two is either the Stokes or the Miller. Stokes are the ones that have like the little bar cages on the ship. And then the Miller is the most common one you guys see. It's basically the big, long, flat plastic one or wood. That's mainly the main two. Sorry. No, you're good. Carries are almost never on the exam. If they are, it's maybe a picture of what type of carry this is. Next. So you have your Huey, you have your Black Hawk, and then you have your Chinook. Basically all you have to know is litters and ambulatory. Just and then the Chinook's primary mission is for evacuation. Just know the litters. Next. 9-line. I feel like that's more just a green side thing. I don't really remember seeing too much 9 lines on the actual exam. Alright. Alright, I'll just go through it real quick. So, in order, this is pretty common sense. Where are you going? Next one, radio frequency, number of patients, need special equipment, tell them like blood or whatever. Number of patients by how they are, they later, the ambulatory. What type of wound do you have? You have gunshot wounds, whatever. Method of pickup. We're going to find you by smoke or something else. Patient nationality, and then are we in peacetime or are we contaminated warfare? If you guys don't know 9 lines, then you're inside command. Just take your pen away. Next. And I never see this stuff in the exam either. They don't really ask what the colors are, flammable liquids. Like, I think that's the last slide for this.
Say if you have to leave, I've uploaded test 3 in there, make sure you knock it out before tomorrow.
I'm going through this pretty fast because like I'm on a time crunch. If you guys need to get in contact with me, I'll gladly sit down with you a little bit longer and get in depth if you guys need it. Just know for those that are in green side, the 2 that change, depending on the location, is the 6 and the 9. It's basically, if you're in a war zone, that's the only ones that's going to change, is 6 and 9. Alright, objectives next. I think you all know what a combatant and non-combatant are. Next. Alright, general first aid, maintain breathing, stop bleeding, prevent shock. I know I've seen that on the exam a few times. Next. So for triage, this changed since I came in the military. So for tactical, you have your priority 1 through 3, and then non-tactical is 1 through 5. The main difference that I've seen for priority 3 is minimum and minor, but they're basically the same exact going through.
You know that definition of triage, French word, sword.
Airway management, don't really ever, maybe jaw thrust or head tilt is the only thing I've seen on there for airway, what type of methods. Next. Alright, types of shock. They're going to go into more detail. You have neurogenic, septic, carcinogenic, but they go in more detail on the next one. Next. So these are the main ones that matter. So hypovolemic, basically hemorrhage. These are going to come more into effect just to know basically what type of shock it is. And then the treatments for it, a lot of times they'll use the whole what type of priority is this to give you a shock, or what type of shock is this. Next. This is just a chart for your own knowledge. I don't really seen this on the exam either. The types of class of shock. Next. Septic shock, so you basically have stool and shit going through, or some type of nasty shit going through your body, which causes a lot of people to die. Next. Neurogenic, basically just think nerve damage, so usually it's with the spinal cord. Next. Psychogenic, basically they're just messed up in the head, so fainting, shortness of breath cause it too. Another thing is hypoglycemia. You start losing mind function and starting to slow down. You can hyperventilate and go into shock from that as well. Next. Cardiogenic, basically like a heart attack almost. Next. Not important. Next. Alright, patient assessment, DCAT BLS. I've never seen anything. This is more field stuff, TCCC. Next. Alright, so TCCC, main thing, care under fire, basically all you're going to do is give tourniquet, field care, basically treat the minor symptoms as much as you can, and then evacuation, the major stuff, you're going to go through there. Like, you're not going to give blood in care or tactical, you give it in the evacuation care.
I've seen where it asks, like, where do you apply self-aid? What levels? TCCC. Alright.
and shot.
Right.
Doesn't make fucking sense.
Care under fire.
Oh.
It's like something, you know.
So self-aid, think of
Right.
yourself. Tactical field is someone helping you almost, other than a foreman.
Good.
Next. So types of injuries. So your lacerations, your cuts, punctures, basically stab wounds, avulsions, basically degloving, amputation, your limb's been cut off. And then treatments, usually pressure dressings or a tourniquet. Next. Fracture, it's going through the bone, it's not going through the, or going through the skin or not going through the skin. Don't ever try to immobilize it or set the fracture in place. Next. Your burns, first, second, third degree, and then electrical and fourth degree. First degree sunburn, second degree basically, further some degree has blisters. Third degree is supposed to be the most painful, and then 4 basically hitting the nerves. Next.
Covered heat
Next.
800 times.
Alright.
We've covered cold.
So, and that should be it. I know this went by fast. So if you guys need to contact me, I'm in Global. I'm over at 1-2. I'll be transferring to 2-2 like next month, but I have no problem helping you guys out before you guys take your exam.
Know how to identify the different burns. Know your rule of 9. I think that's on every damn exam. I'm telling you that Master Chief Fraker updated study guide.
That's really good.
Yeah, it's good for your ditties and learning like the stupid shit you have a hard time retaining. Alright, I know it's super outdated, but it's still there. Pass it to your junior sailors. Go over it in the morning in your BAS. Just short 10-15 minutes. If you guys are teaching this, that's what helps me. I go and I teach this to my junior guys, and as I teach it, they retain it, and then we talk about it throughout the day, and then I retain it more. So that's my method. I know Chief was talking about all these methods, so. But go ahead and get out of here. See you guys in the morning, 07:30. I'll probably, honestly, if you guys are good with it, I'm gonna start right at 7:45, so we can speed up this timeline.
I probably won't be tomorrow.
Okay.
I got PLS in the morning.